Priority Lead. It's going to be a digital story, but Johan and Jane are here to answer any questions afterwards. So Claire, if you could start the story, that would be great.
How can nurses look after others if we can't look after ourselves?
We're not supposed to be like this. You know, we're professionals, we're supposed to have it all together. We're the ones that are there to help.
We're not superheroes. We're individuals who do unique jobs, and it is our job.
You can't come to work and not bring your whole self.
And it's recognising that sometimes the stuff that we have to deal with on a day-to-day basis takes us to the point of where our lives come into question for ourselves.
If our well-being isn't a priority, then we can't deliver the best personalised patient care.
There's a huge connection between staff well-being and quality of care. We know if our staff are happy and are coming to work and enjoying their work, it's better for patients.
I think we have to make so much more spaces for our professionals to allow themselves to be human.
Our staff really deserve every support they can get. I can't think of a tougher job. When we started to think about what we really needed to improve in our health board, one area that quickly came up was staff well-being.
I linked with Johan and we started having conversations about arts in health. Arts, I see as a significant vehicle within health. We have then been fortunate to get some funding to help us develop Sharing Hope.
So I feel that Sharing Hope is a very unique project in that it's brought the worlds of art and health together in a very equal way. It's been co-produced between myself as the arts coordinator and Jane as the suicide and self-harm prevention lead from the very beginning. It's at the highest quality in every aspect. We've been able to take into account both the artistic quality of it, but also the concerns of our staff, because Jane is a mental health nurse. She's been working for the health board for over 30 years. That brings an authenticity and depth to our project.
Sharing hope. It's the hope that, you know what, we can do this. We can move forward, we can be together, we can come out stronger. We wanted to join up the dots. We didn't want one person thinking, I go home at night and I think to myself, I don't want to go back tomorrow. This is not what I signed up for, but my heart is this is what I am and this is what I do and this is my passion. So it's listening to people and it's understanding, and they are the most generous things we can give to people. But if we can wrap that around something like art, the power of arts in health. And the unique thing about art and any art form is sometimes you don't have to go to the depth of that emotion or the depth of that pain. It feels natural. It's a way that feels comfortable. And I think that's the magic of Sharing Hope. We're allowing a person to come into that first phase of really exploring how they feel and what they want to share.
It's a very inviting way of seeking support. It's like a sort of friendly open door that people can walk through without having to say I'm ill or without having to be diagnosed or anything like that.
It doesn't take anything away from the existing support that's available for staff and volunteers within the health board, but it adds to it within the workplace, within work time. It gives people a sense of, you know, fresh air, I suppose. It's like just stopping and being. I believe that all human beings are innately creative, and creativity is an important aspect of health. And I think in this particular context, creativity gives people a space to reflect, to process, to make sense of things.
So it's not an individual practice, it's not one-to-one. We're inviting ideally groups of staff from across hospital sites, wherever the setting may be, to come together and share, first of all, the enjoyment of creating something, whatever it may be, but also have that space outside of their usual practice, whether it's in wards or offices, to have conversations that then hopefully become really important ones that can continue outside of the sharing hope space.
In the Stone Age, how long humans have been doing that as a form of expression, help and therapy.
But it's amazing what happens as a result of people coming into contact with these fairly basic arts materials. I think the very nature of clay helps to ground people and for them to feel connected to something quite soothing and calming.
It's just, I can feel that my heart's slowed down and my shoulders are relaxed. So I am actually feeling more relaxed.
I suppose because I've been talking and I've been saying things, I suppose, because I'm doing this now, there's something.
It's soothing you.
Yeah.
I think what surprised me most is how meaningful the small little moments of management and students side by side, the joy of them being able to access each other as fellow humans, is a levelling space where everyone can come together as people rather than as staff.
I'd started to really focus on what I was trying to do and my painting, my drawing, and it felt mindful. I think there was a mindfulness moment, so it was quite nice just to take some time out of a busy day and a busy week and take a moment to think about my well-being.
This project depends upon the support of management, and management are really key in enabling staff to engage on this kind of a project.
It opens up an opportunity then from a management perspective to ensure that that person has the right support for them as well. So it does provide an insight into how staff are feeling. Some people may not come to you and verbalise what's going on, but to have time to draw it, it enables it to come out in a different way.
Using the arts is probably quite a different way for a lot of people, and probably something people hadn't experienced before, but the impact and the feedback is hugely significant. It clearly makes a positive difference, and it's absolutely, a real feather in our cap, I think, the Sharing Hope project.
The key bit for me is looking at the evidence of the outcomes. So it's not the piece of art, although the pieces of art are great. It's actually what happens in those groups. It's the interactions, not just with the artist, but with the individuals. For me, it's the comments of individuals who've been involved. I mean, we've got some evidence that clearly suggests that people were at the point of considering suicide as their only option, and then they've engaged in a group, spoken to people of like mind, and it's allowed them to be able to express those emotions in a safe, secure environment where they felt supported, and therefore averted them from taking that ultimate action of taking their own lives. So the evidence is critical.
That dopamine you get from just looking at your phone.
We all kind of shared stories. We were all talking about things that I would have never spoke to these people about if I'd seen them on the ward or in the hospital setting. So it's quite good to get to know each other a little bit better.
That hour could make a difference.
Yeah.
It could be a breather to go back to work and get through the other half of your shift. And if you're in a better frame of mind, your patients will benefit from that as well.
Our profession is like stressful, so this session takes us away from our stressful work unit, and we are not thinking about that, and it also helps us to be with our colleagues and friends.
I'm not an artist myself, but it's always nice to explore a different part of your creativity when someone gives you the opportunity, which is what I think these Sharing Hope sessions are really good at doing.
We're also very conscious of securing the sustainability of Sharing Hope, so people can rely on it sort of being there in the future as well. At the most, we've had something like 150 members of our staff get support with our artists in 1 month. And that's a lot of people, and some of them might depend on us for that support. And once we put that support in place, we don't want to just take it away.
For us, this is the beginning, and what a fantastic, amazing beginning it's been. We've created amazing platforms, amazing forums, amazing artists. It is a privilege. It's extremely powerful.
What's been demonstrated by Sharing Hope is that this is a vehicle that can be of massive assistance to the staff that work in our services. I think if I wanted to really see this work, I'd want to see it across the whole of Wales. I'd want to see the model replicated, but applied clearly, because what we do may not be right for the next health board or a health board further away. So I'd really love to see the model used and embedded across the whole of Wales.
It's so lush, I'm so chuffed. It's nice as well that we've made it now.
Thank you. And as I say, we've got Johan and Jane here. Sorry. Before I open up to questions, Gareth, as nurse director, is there anything you'd like to add?
Do you know, I think we struggled a bit with the neck there, didn't we? So I think, you know, the killed that. What got over the principle of the concept here. If you look at COVID, it's like COVID never happened, isn't it? You know, we just a couple of years later now, and we've been pushing on as normal, but the impact that COVID and the impact of working in the NHS has on people, it can be enormous, it can be really challenging. So this approach, while different in many ways, is having such an impact on our staff in helping them walk through where to seek help and really just be part of a group having a similar discussion around where they are. It started off in our suicide prevention quality priority, but you guys have really sort of taken it on and taken it to the next level. And I hope you saw at the end there the 3 or 4 awards that the programme has actually won on a UK-wide basis. But if there's any questions, then we'd be pleased to take them.
Excuse my cough. It is the tail end of the cold. Are there any questions? Yes, Nicholas.
I want to say it's great to see people doing such positive work. I'm just wondering whether people, our staff from across all our sites are able to access it.
Well, that's our aim, is to offer it to all staff. So obviously with a fairly limited budget for this pilot project, we've been able to offer it at Newport Talbot Hospital, Kevin Coyd, Singleton, Morriston, the Alwyn, but we have made it available online. So we have an online art group as well, which is available to everybody. And I'm currently working on a funding bid that would allow us to offer it also to primary and community and health and learning disability as well. But I mean, the demand, so to speak, is there, and we have the capacity to deliver as well. So yeah, if we have the budget.
Thank you. Oh dear, sorry, it will go. Any other? Yes, Nuria, and I've got Karen.
I'm delighted with this project. This was something that we supported with charitable funds, and it's great to see the work, isn't it? Though we've been discussing quite a lot, I think there's probably more to do, joining together, working in partnership with others, not just in the health board, but outside the health board. So yes, there's tons of opportunities out there. And I think Nicola's point is we really do want it to go everywhere, don't we? It's great.
And just to comment on the scale of it, you know, Ivan, I should apologize to Ivan because he's made a beautiful film that we didn't manage to show properly today. You know, he only visited 3 sessions. We've delivered over 140 sessions in 2 years. And that's, you know, hundreds of staff that benefited from this. So this is just a little glimpse of it as well.
And the work that we're doing with our wellbeing and staff wellbeing support is working really, really well right now. Is that the experience? Yes.
Yeah, absolutely. You know, when we have done sessions, there have been pockets of times where staff have really turned up at the point at which, you know, they cannot see a future tomorrow, and we've been able to then get them that support and navigate them to the right place at the right time, as we should in any form of anybody that sort of diverges any feelings of any there. So we've been able to do that.
So our chair is temporarily, I hope, indisposed. So I'll make to the rescue. Any more, Darren, go ahead.
Thanks, Steve. Thank you. It's really powerful. You'd be pleased to know I've not got my finance director hat on for this one. I've got my capital hat on. We're about to develop, and you may have seen the front of Morristown, we're starting to liberate the space. And we've secured significant resource to put some clinical services in there, but we've got resource to put some staff welfare space in as well. So I think just outside of this, and then it was Lee Morristown, and I think it's a huge opportunity to incorporate some sort of arts initiatives in that space, you know, just with like insight and support them to help us create something where you could use it, because it's not just what you do, it's where you do it, isn't it? And in some of those sense, it's really challenging to get the rooms and get the space to do it.
The biggest challenge. Yeah. So we have a space in Kevin Coyd at the moment called Teach Less, which translates to well-being room, I think. And that's been, I think, one of our most successful groups, because we've had the same space every week and staff know where to find us. So we can have very interesting.
Yeah, thank you. Thank you.
That's Steve. I think that one of the things is it's really important that our patients hear this as well, because that triangulation you're making, that staff's happy, patients will get better care. I think it's a really important message, isn't it? And displaying a lot of the work they've done, that artwork out, so that patients can see what we are doing to look after our staff. Because we hear it a lot from patients, isn't it, that they are worried about our staff, isn't it? And that is, I think, a message back to say that we care as much as, you know, a lot of patients do. And so I think it'd be good to demonstrate that through showing that work they're doing, and displaying that and making it more public.
There will be a 2-week exhibition in Eastport Talbot Hospital, 2 first weeks of July. We'll make sure to have invitations going to everyone.
It's open. I think that's everybody.
That's another one. Okay. Well, thank you very much indeed. It's really good having had, I see the funding come through from the Arts Council. It's really good to see this coming and see the difference that it's making. When I share your ambition to make it available to all, because I think it's a really worthwhile project, and it has we've got the awards as well. We have, for which congratulations. Thank you so much. No, thank you very much indeed. You're not welcome to stay, but you may have other things to do. Okay, thank you so much for your time. Okay. So if we can now move to the formal part of the board meeting. We've got 2 sets of minutes to approve. First of all, for the 28th of March, and then for the 10th of April, the special board meeting for EMATS. Can I ask, first of all, whether there are any questions of accuracy on either of those sets of minutes? No. Are we happy that all matters arising have been picked up? Excellent. So happy to receive those as an accurate record. Good. We've then got the action log. So all actions do have a status update of being closed. And the request has been received to close the following action, which is the annual plan, with a joint paper to be brought on board to the board on engagement with staff in the annual plan. Are we happy with that? Do you want to take that?
Yeah, it's covered in the chief exec's report, but in essence, it's an ongoing piece of work where we're already doing it in terms of engaging with staff on the back of it, but obviously adjusting the messaging as we go on over the next few weeks and months.
Fine. Happy with that, everyone? Yeah, great. Fine. So now we have my report, which is the written report as always. The most important aspect of which, of course, is the new chair, Jan Williams, who will start on the 1st of June, which has now been confirmed. There are comments on the various different external relationships and meetings that I've had, site visits that have been taking place with independent members, board effectiveness and the chair's action that have been taken since the last meeting. Any questions? Otherwise, I will move to Richard and the Chief Executive's report.
Thank you very much. Thanks, Emma. So I'll refer colleagues to the written report itself. And if I may just pick up a few highlights from that report. The report covers 8 different areas actually, but I'll pick those up in turn. I think the first thing to say that over the last few weeks, a lot of my time and that of the executive team has been dominated by our work on improving areas of targeted intervention, enhanced monitoring and our financial position. And I think that does reflect the importance that we place on these areas, our concern about these areas, both in terms of an executive team, as a board, Welsh Government, but also our staff and our patients. The meetings that we've had on both targeted intervention and enhanced monitoring with the Welsh Government colleagues have been very constructive, and they will be covered in depth elsewhere in the meeting. In the last fortnight, we've also had our biannual joint executive team meeting with the Welsh Government. Another meeting that went very well with reflections on the positive improvements that have been made by the Health Board, particularly in regard to planned care, while we and they also acknowledge their concerns about the financial position. In terms of that, we've been very keen to engage more widely on that and to explain and to seek engagement from our staff. And in my weekly communication to staff last week, I highlighted our concern about that financial situation and the need for everybody to consider how we all ensure that public money is spent wisely. And I asked for feedback. I asked staff to contact me with any ideas or suggestions. And I'm pleased to say that several people did get in touch with responses, ideas and feedback about how we could deliver our services more effectively and efficiently. And their feedback is now being followed up, and I'm continuing this week to engage with staff around that. Again, seeking thoughts and contributions about how we secure the best possible value for every pound that we spend. There's a highlight then in terms of a report on engagement, which is the work that we've been doing with Newport Talbot County Borough Council in securing a replacement for healthcare facility at Avon Valley, which is good news. There's more detail in the report. There's some detail about the National Clinical Support Hub. So this following transfer of the National 111 programme to the NHS Executive on the 1st of April 2024, Swansea Bay agreed to take on the operational management of the National Clinical Support Hub for a period of 12 months, during which time further decisions will be made about how that is managed going forward. An important report this week that I'm sure everyone will have seen, and that was the final report of the infected blood inquiry, which was published on Monday. There's directions to the report from that website. Swansea Bay University Health Board hosts one of the 4 haemophilia centres in Wales, and predecessor organisations were involved in the delivery of care to people requiring blood products. And we know that some of those patients have subsequently been identified as having been infected as a result of receiving those products, and completely acknowledge that they and their family members and loved ones have been affected by the consequences. And to that end, we acknowledge and apologise unreservedly for the hurt, pain and suffering that was caused, and would like to take this opportunity to extend our sincere apologies to all of those affected. And of course, our deepest condolences extend to those suffering the loss of a loved one. While there's been much progress in the way of improved technology, screening of blood products and more stringent infection control in place, we accept that there will still be learnings from this public tragedy. There are resources available for staff and public on the website, and the Haemophilia Centre in Cardiff is also providing support for all patients with inherited bleeding disorders within the network, including people from Swansea. And the hyperlinks to those relevant websites are in the paper. On maternity and neonatal services, last week Management Board approved the reopening of the Neath Talbot Birth Centre and the home birth service, subject to final approval by the board. This followed a comprehensive review process involving a number of formal gateways and significant staff input engagement. As a result of issues raised this week by one of our recognised trades unions, there'll be a short delay in bringing the formal proposal for reopening to the board, and this updated timetable will ensure the board is fully briefed on any issues and has sufficient assurance regarding the management response before the final decision is made. And furthermore, since the last board meeting, the chair of the Maternity and Neonatal Services Independent Review Oversight Panel, Margaret Bowen KC, has announced the experts who will be undertaking the review, the clinical review, the engagement review, and the governance review, and the details of those individuals are provided in the paper. Those teams will report to the Oversight Panel, which is chaired by Margaret Bowen. And as the biographies of the individuals, there's a hyperlink in the document. In addition, an online event was held this week on Monday the 20th of May to enable service users to meet members of the Oversight Panel and to input their views and ask questions about the terms of reference for the review. The meeting was a useful opportunity to share information and was part of the extended listening period for the terms of reference, which ends this coming Friday, the 24th of May. CLICE also helping gather views and comments on the terms of reference via an online survey. There's some detail in the report about a pilot of a revised visitor policy, which we're running at Neath Port Talbot Hospital, and where we're seeking the views of patients, visitors, carers and staff, and there's detail in that about how that's working. And then just to say that we've done a lot, particularly with Richard and his team, about how we engage and communicate with staff. But as part of those continuous efforts to strengthen those communications, we will shortly be launching a new regular engagement event for staff. This will be hosted by me as the interim chief executive. The plan is for me to have other members of the executive team available for those meetings as an opportunity to share key messages, provide updates, as well as to receive feedback and questions. And that comes on the back of the introduction of the midweek message, which has been a regular feature, and all staff get that email, and we know that it's regularly read by approximately 4,000 staff. There's a section on Staff Recognition Month, and I would like to draw board members as well to the congratulations that are due to several members of staff who were successful in the Healthcare People Management Association HPMA Cymru Awards in 2024, which includes for the wellbeing category Sharing Hope, who we heard from earlier on in the patient story. And then finally in the report itself, there's an update on the charity of Jiffy's Bike Ride and about our fundraising efforts for the charity, which are ongoing in terms of raising money for what we hope will be the Cancer Centre, for the NICU, and for other good causes within the Health Board. And then finally, Emma, it falls to me to say thank you, and in your last board meeting, just to pay tribute to you as outgoing chair. Personally, since starting in a role as chair, Emma's been a huge source of support, advice and challenge, both to me and the executive team. And I know amongst the wider leadership group, including our independent members. We've made a huge amount of progress during your tenure, Emma, and much of that is down to the way in which you've led the organisation, championing the needs of patients, ensuring good governance, and living the values of the organisation, both in board meetings and making that very visible beyond. And the executive team and I would like to place on record our very sincere thanks to you, Emma, and to wish you all the very best for the future.
Thank you, Richard. Thank you very much indeed. I might say a few words at the end of the board, but it's a great organisation. It's a really great organisation. I'd like to say a few words at the end, because I think it's been a journey. This is a great team. But let's get through the board. Let's get through the business of the board first. Okay. Any questions for Richard on his report? Yeah, Muriel.
Keeping arrangements, Richard, something we touched on your report in terms of your actually consulting on these, and I just wanted to get more detail as to what that will involve, given that it's been a hot topic throughout COVID, where we had to restrict visiting for our patients, which has been ongoing, and then we reverted back in some areas, but not all. So what is the aim of revisiting the policy?
So the pilot's going to run 4 weeks from where it started from the 6th of May in those areas. I think what the pilot acknowledges is that there is a need for formal visiting times, which allows staff to perform key functions like if medicines provide direct care, but also allows for that flexibility, recognising that there are many patients, in particular actually need for Talbot in these areas, where relatives provide care for whether it's cognitive impairment and that interaction between the patient and the family is key. And also just that social element. So it's allowing for fixed visiting times, but also the discretion for varying that for different relatives. In terms of how that feedback's been received, I can't give you a direct, Richard.
So there's a questionnaire that's been shared. So obviously individuals have an opportunity to feedback that way. I'm sure that the staff on the ground in East Talbot as well will be getting feedback. I think it's an opportunity for us, once we consider the feedback and look at whether or not that we then need to tweak what the rules are. It's an opportunity for us to be clear and to be very clear in terms of how we explain that to the public as well, because I think that's one of the challenges we've got. It's quite complicated. So there's an opportunity here to improve the way that we're able to communicate with the public about what they can expect from us.
Can I just ask a question around partners? Will you also be sharing information with partners so they can reach out to as many patients as use our services?
Yeah, so we've been publicising the survey online, so sharing it on social media, making partners aware of it as well. So the main route is to feedback via the survey, and obviously we've still got a bit more time left as well, so we'll continue to share that on social media and get it out in other ways too. The more people that respond, the better, because it's a real issue, and we want people's feedback.
Thank you. Tom.
So it's a quick one on the HPMA awards. I was there because I was speaking on the panel about AI and future workforce, and it was just great to see how many highly commended and obviously successful awards for the health board. So it's a real strong show from Swansea Bay.
Excellent. Thank you for that. Is your hand up, Nicola? No, fine. Okay, great. All right, so we'll move on then. Right, so the first, we're into quality, safety and performance, part 2. 2.1 is a report on targeted intervention. So Deb.
Thank you, Chair. It's quite a lengthy report, but it won't be long to present it because most of the key items that we've already gone through as part of Richard's update as well. So just by summary, so we know the areas that we're in targeted intervention for, so cancer, planned care, UEC, urgent emergency care, healthcare acquired infections, and CAMS, which is child and adolescent mental health services. We've had our first formal round of meetings with Welsh Government colleagues, and the next formal meeting is scheduled on the 17th of June. As the report details, we've got a formal internal mechanism for monitoring and managing the targeted intervention work programme and the performance aligned with that. And the paper gives detail on specifics of where we're in escalation, what the criteria is, and then specifically what the criteria is for de-escalation. And I won't go into too much detail on the overall work programme. I'm happy to take questions on that, but just in summary on where we are currently. So cancer, our target for cancer as part of targeted intervention is to achieve 60%. And we're ambitious to achieve that by the end of June, so the end of Q1, and sustain that. Alongside that, then Welsh Government has also brought in key performance indicators for all health boards to achieve, and the target for those is also 60% in year and 70% by the end of March. And we'll be, obviously, if we achieve the 60%, we'll be in the pack then to move towards our 70%. Members be aware that we had quite poor performance at the beginning of this calendar year, so January and February were poor for us. March did improve, so we achieved 56% against the target in March. So we're not far off on the 60%. We anticipate April will be a similar, and hopefully then we can recover that as we go in through May and June. One point to note on the cancer performance, which will come through perhaps in the performance report, members be aware we've put the first robot into Morriston Hospital specifically for treating prostate cancer patients, so to do our own prostatectomies. Because we've got that in situ, we now have more capacity to treat those patients, and we've got quite a significant number of gentlemen who've already reached the target that we'll be bringing through now at a rate of knots because we've got the capacity. That will impact on the performance in that tumour site, but it's still absolutely the right thing for us to do. So just bear that in mind if we don't quite see the performance in that tumour site as we go forward. On a plan care perspective, as Richard alluded to, feedback from Welsh Government has been largely positive, and certainly the metrics that were shown in Team Wales recently showed us as at the top of the pack in delivery for planned care. The targets that we've been asked to achieve in planned care is that no patient waits longer than 52 weeks for a first outpatient appointment. Members be aware we achieved that last October, and we've sustained delivery of that target, and we remain the only health board in Wales other than Powys to deliver on that key metric. 104 weeks is the full referral to treatment target, and the target for us is that 100% of patients are seen within 104 weeks. The target at the end of March was 99%, and we achieved 98% against that target, and that was broadly where everybody else landed across Wales. The target for us was to achieve that this financial year. Welsh Government has brought in a stretch target to achieve that by the end of December for all health boards. And if our plans are in place to deliver at the end of March, then we should be able to deliver that by the end of December as well. Obviously, the annual plan pending on what results we've got available to us to do that. The other target is that 52 weeks referral to treatment full pathway, 80% are seen within 52 weeks. We already deliver that. Stretch target for this year is that 100% are seen within 52 weeks. That's the ministerial target for 24-25. That's going to be a challenge for all health boards to deliver on. We're comfortably within 80%, but then it's a maths game on where we get within the 100% bit. The follow-up waiting list, that's a challenge for us. We know we've got a lot of work to do on that in this first quarter. We do have a technical issue in our reporting on that at the moment. So there's a flaw within our report that we're relying on DHCW to help us resolve. So currently I can't give an accurate report on where we are against that measure, but hopefully we can get that resolved relatively soon. But we know we've got an issue to sort out in there anyway. Ophthalmology is for 65% of patients who are category 1, so the highest priority to be seen within target date. We achieved that. Diagnostics for 80% of patients to receive their diagnostic within eight weeks. We achieved that. Endoscopy, so it's 80% of endoscopy referrals to be seen within 8 weeks. That's an issue for us, so we know we've got a challenge in endoscopy, and we're working on a recovery plan specifically for endoscopy. Therapies is an 85% target for 14 weeks. We comfortably achieved that one. And then there's a couple of new ones that weren't in the original document that came through from Welsh Government, and that's how we manage our complaints and concerns and what we do with patient experience and surveys, and we're working up the plans for those ones. Then moving into the urgent emergency care space, targets are that we see an 11% improvement in ambulances and patients on ambulances brought into the emergency department within 1 hour. We are seeing some improvement in that, and actually only Cardiff delivers better performance in that area than Swansea Bay does. The challenge for Swansea Bay is those patients that we don't bring in within an hour wait far too long outside the department. So we're also keeping an eye on that measure to make sure we're covering off both, and it's a quality thing for us rather than just a numbers game. As the number of patients who wait more than 12 hours in the emergency department, we've got to see a 7% month-on-month reduction in the overall total on that, and we're gearing up the metrics to see what that looks like. Medium time for patients to be seen by a clinician to be within 60 minutes. We achieved that already, and with the health board in Wales that does that. And again, within urgent emergency care, it's our concerns, complaints, and our patients' experience that's been brought in. CAMS service. So the only target we're not achieving in the CAMS service is the 28 days to assessment, the first assessment of those. Members be aware through previous reports that was due to a shortage of staff within that service and due to loss of agencies. Performance in February was 31%, that improved in March to 40%. So we're on the right road on that, and we anticipate achieving that compliance relatively soon. Healthcare acquired infections, reporting timelines, and that means we haven't got the most up-to-date figures for where we are against healthcare acquired infections, but the governance is well embedded into the service now, and the quality metric that they wanted to achieve is in place. And the one metric where we're an outlier and we know we've got work to do is performance against C. difficile recordings. And I think we're looking to get about 10 a month, and we're on about 20, I think, at the moment, is the latest figures that we reported. From a plan care perspective, the other thing we set our stall out internally, Chair, was that we would see no deterioration on the performance that we achieved at the end of March, which was a really positive position for us. We maintained that in April and improved on it across all areas, and looks like May will follow suit. So we are on track to continue the improvement that we've seen in plan care. And the biggest ticket item for us from a UEC perspective is our frailty strategy, and that's well underway with the plans to get that frailty unit open by September. We know focusing on our frail elderly attendances into the urgent emergency care system will give us the benefit for the patients and the overall system. A large amount of focus on the medical rosters to make sure we've got senior clinical decision makers at our front door, and those rosters will be changing either during mid-June, towards the end of June. So we'll have better rosters in place there, and that's as a result of the improvements we saw when we go through the industrial action periods, where having those consultants available for longer gave us a real boost in having managed the patient flow through there. And operational grip and control. So we know we needed a bit more support on the ground, and we interviewed for a secondment in the service yesterday. It's an internal position that we'll be moving across to support how we bring together the operational control on urgent emergency care. And I'll stop there, Chair, if there's any questions then.
Thank you very much, Deb. And of course, Performance and Finance Committee has also received significant deep dives in these areas as well over the last couple of months. Are there any questions for Deb? Yes. Pat.
I thought that the tables you've got in the report are really helpful in terms they give you a sense of distance to travel as well. So they were really helpful. I was thinking of performance management. And I was just wondering, how are the targets set? So that was one question. How did Welsh Government come up with the targets that they did?
And possibly comment on that one. I don't think perhaps they do seem sensible though, to be fair. They had a little bit of a stretch target, but they're achievable.
And they've been set across Wales.
Yeah, they are now. So we were the first, obviously, from a targeted intervention perspective to receive them, but they are being mirrored now for all health boards to achieve.
Yeah. And the other questions I had were around the governance. Obviously, it's extremely complex, loads of moving parts in this, and I just, wanted assurance about the robustness of the governance, really. I know you've got your weekly meeting, which is an hour, which means good standard reporting and disciplines around that. And then it goes into management board, and I just wondered, what is it a standing item? What kind of coverage is it given in management board? And we'd have to reflect on that in performance and finance as well, but I just wanted a bit more detail on the governance.
So this month was the first formal report into management board, and I literally used the same report to go into management board to come here. It gives everything, so probably future reports I'll tether as to the needs of the receiving boards that we need in there. It gets a lot of airtime, so obviously all of the measures that are in the targeted intervention report are also covered off in the performance report as well, so there's no difference in any of those. So it's through usual business reporting into management board plus an additional targeted intervention report. The governance on a weekly basis, that's just starting to bed in, so I am struggling with an hour on a weekly basis. I've got to be honest, a lot to get through in an hour, so we are trying to make sure we give it the airtime that it needs, but it's quick and snappy so that we can get on with the day-to-day business. And all of that is supported by weekly meetings within the individual work streams with the triumvirate leads that lead on those as well. So it's very, as Richard alludes to, it's very all-consuming at the moment because it's the only game in town for us in managing where we're going.
And those subgroups have got project support, in terms of...
Yeah.
Thank you. Good question. I've got, do you want to come in on that?
If I could just pass question, I think the question's very good. So we were set our targets for improvement through targeted intervention, and then following the agreement of those targets, Welsh Government did present NHS Wales with a slightly different set of targets, new key performance indicators for the remainder of this calendar year and then into the end of the financial year. Just to clarify, those, although they were presented in a slightly different way as percentages as opposed to numbers to our targeted intervention figures, they broadly align to what we've agreed through targeted intervention, with the exception of achievement of 104-week reduction of 104-week weights, which originally had been the end of March next year, but with the new measures was brought forward to December this year. We've clarified with the Welsh Government that for health boards not in targeted intervention, the aim is for December, but the nature of targeted intervention means they're acknowledging that there are particular system issues that make delivery a challenge. That's been set for us as a stretch target rather than necessarily a hard stop. But actually, when we've looked at that, delivering those, into particularly around a financial challenge, bringing those forward doesn't really have any impact. We will achieve those by December with essentially the same, without incurring any additional cost as when we would, if we'd achieved it by the end of March. But we're conscious that in terms of overall delivery and how things might change, that is set for us as a stretch rather than a hard KPI, which will be.
Okay, thank you. I've got Nuria next and then Darren.
Thank you. I thought it was a really thorough report. I had some similar question to you, Pat, around governance. I think for me, there is, the numbers are really important, but there is what lies behind those numbers. So it's about assurance that we're keeping an eye on quality, equity, clinical prioritization alongside everything we're doing around numbers, so that those patients that need to be seen first are being seen first.
And that's the thread to everything that we do, to be fair. Certainly from a planned care perspective, we are developing new communications to go to patients, how we communicate what the script from staff is to make sure patients are aware of any urgency in their need to be seen. A patient access policy that clearly articulates what patients are seen in clinical priority urgency first, and then chronological order to make sure that we are treating the most urgent patients, but then the longest waits as well as they need to be seen. All that's coming together as part of the patient access group.
Thanks. Okay, so I'm sorry, Rena, I missed you out. So it's Rena next, then Darren.
Yeah, it's just a question about healthcare acquired infections. Because of all of the areas that are within this report, that's the one that still worries me. Because of the fact that we have such an older state. And this came up in the review panel that we attended as independent members from Quality and Safety. Because a lot of the investigations into why these infections had arisen, the estate came into the discussion. And I'm just wondering, is there any opportunity within targeted intervention to get some additional capital investment into our estate to sort out some of these issues?
Darren, do you want to comment on that?
Yes, thank you. It's really good. And there's a couple of points. One is we reprioritised and reshaped the profile of this year's discretionary capital plan. It's the $500,000 into this straight away, recognising the pressures. That's not sort of fundamental revolution of wards. This is about getting wards back to being clean, tidy, floors, paints, etc., to allow us then to do the cleaning and other things we need to do to keep the environment as safe as possible. And on top of that, we've got the thing called the EFAB programme. I'll touch on this later in the estates report, but that's allowing us to also modify some of the roofing and just improve the integrity of the roof as well. And we've just recently submitted bids to the value of $9.5 million for furtherance of that money as well to help. So we've juggled the priority to meet targeted intervention. It means we're doing something else a bit later on, but actually I think that's really appropriate in the scheme of what we've got. In the spirit of getting more from government, I think this extra bit that we put in is probably the route forward. But that's every health board, it's not specific to us.
Thanks, Rena. Good point. So I've got, actually, Darren, you were next. Was there something else you wanted to?
Just a very quick comment on the governance and the maturity of the process. I've been with Deb since the inception of these meetings. I think it's fair to say the start were the formative discussions. It was a lot of discussion, a lot of how are we going to do this. When it's now matured into a bit more of a rhythm where there's action plans, where the metrics are being analysed at each meeting. That's generating further conversation, which is why the hour is pressed. But actually, it's come a long way in terms of what you'd expect to see from what is effectively a performance recovery programme with clear actions, action logs, and the numbers being watched as well. So that's context in terms of where we started and where we've got to today and perhaps where we'll go.
Thank you. Helpful. Andrew.
Just on the point around healthcare associated infections as well, I think that the estate is absolutely key, but there are other areas we can also tackle, and I think there's a real plan around it. So antimicrobial stewardship is a significant factor, and we need to be able to make sure that the focus is back on that, and that gets embedded as a priority. There's also work around the IPC compliance and our hand hygiene, and all of that work will feature as part of the wider work you're going to do to long-term reduce our healthcare associated infections. And we have now revamped the whole governance on how we're going to be communicating to service groups? How are we going to discuss their hotspots on a weekly and monthly basis? And how are we going to be really having those targeted discussions, what they are doing to improve those, and how they're ensuring that their eyes are on those hotspots so that they don't escalate into anything bigger. And we've got also a big sort of focus on quality improvement, trying things which are evidenced in Wales and other places have tried, and we should be implementing at pace. So there are quite a lot of initiatives we've been discussing with nationally as well, and with other health boards. They've tried and actually had some impact. So we are really trying to get into that space of, we can't just sit back, we really need to try to be quite proactive about it. And then on the point around the sort of prioritisation for patients, I think in one of the areas in the frailty strategy is very much that, because this is a population where we really need to focus on, and they're not getting a great deal. They're going through our unscheduled care system. So when you talk about looking at where those patients' needs are, I think that's very much addressed in the strategy.
Okay, thank you. Just coming back to infection prevention control, I read that we're being held to account for the hospital-acquired infections, which is good because it separates out the issues are different. So 2 questions. When will we know what those numbers are and how we measure ourselves? And secondly, linking to Nuria's point, how do we make sure we don't lose the different actions and influence that we need to reduce infections in the community as well, once we're only held to account for hospital acquired?
Yeah, if I can come back on that, I think it was quite a bit surprising that the focus is only on hospital-acquired infections, but we are able to distinguish those. It's not sometimes very clear where the infection has arisen, so there is a bit of grey area, but we are able to give the data on both. That doesn't mean that we should stop making the focus on community-acquired infections. So they are very complex, and there's a very different priorities and focus needs to be happy. We're dealing with infections in care homes, in people's homes, where it is very difficult to put IPC measures in at times. You're dealing very much patient-facing approach as well about what they can do to prevent their infections in their own homes. So it's a very different audience, it's a very different problem profile really in the community, and it's much more multifaceted because of the geography and the services we need to reach. So the focus hasn't stopped on that, and I think you're still continuing to work with all service groups and not just the acute sector.
Okay.
Yeah.
I think that's a brilliant appreciate. So I suppose the only thing I'd add there is some focus work on avoidability and getting into a point whereby every case is reviewed and we know why it's happened. We know if it could have been stopped. We know how to stop it. So I think moving forward, that sort of granular detail around all these aspects will help in terms of reducing completely.
Yeah. But there is something particular about hospital acquired, I think, because we are effectively giving it to them.
Yeah.
Which is different to not helping them prevent it getting it themselves.
Yeah. There is a difference, but if somebody gets infected at home or in a care home, they come into our hospitals and they bring it in, so we shouldn't lose focus on
absolutely
on the community. That's why I think, like in Julia, it was strange that they have differentiated between the two. But I was at the Pan Cluster Planning Group meeting yesterday, and they're pushing ahead in community surveillance of these infections. So it's the work is not being slowed down or avoided just because we're not under TI for that.
No, good. Excellent. Okay. So yes, do you want to come in on this? Yeah. Okay. Yeah. Jennifer, and then I've got Jean.
Yeah, it's just to pick up on that very point, because 40 to 60% of our infections come in from the community.
Yeah.
So as part of the new responsibilities now that are being transferred out to the health boards, there's the regional health protection framework, and within that includes elements around communicable diseases and infection prevention control. So there is proactive work going on with our partners. We have a regional health protection forum where we are working with our local authority partners who have a remit and a role within this. And so actually the IP&C elements forms part of that work programme. So we actually do have quite a proactive approach in terms of how we go in and audit, because that was some of the learning through COVID about what the general compliance was, and understanding of how the rules applied in situ, especially in somewhere that is very busy, and often, you know, the complexity and the need to respond to patients' needs in the moment can sometimes override what is considered good practice. So there was some observational work that was done to look at through a behavioural lens, as opposed to assuming that it was more knowledge that was needed, really understanding behaviours in situ. So some of that work is continuing as part of the regional health protection framework and function that we are developing, and we now have an expectation of being able to deliver in partnership across the region.
Great, excellent, thank you. Okay, Jean.
As we asked to consider and approve the additional results request. Firstly, I'd like to say it's a really comprehensive report. And I think what you can see, you can measure, and we can already see the benefits of the successes that you're having. So well done to everyone on that. But in terms of the resource, can I get some comfort that we're not again creating roles purely because this opportunity is there? Are we drilling down to the productivity savings that could be made by utilising existing staff? And I just want to understand that people appreciate how we can look at providing additional resource differently, as opposed to appointment, giving others the opportunity to step up.
Yeah, and also just for the record that this is within the annual plan that we've submitted.
Yeah.
And just to give assurance, so Jane, you're absolutely correct. It will be a move within the organisation. So it'll be one of our existing staff stepping up into a more senior role to provide the support that we need. And it may not be that a like-for-like backfill, so there will be some efficiencies within what we do. The decision to put that additional resource came in as a result of our visit to Cardiff. So Cardiff does very well in the urgent emergency care space, particularly around bringing patients in off ambulances quickly. And when we went there, it was obvious they had a much bigger front door resource to support and make sure we've got traction in that space at all times. We rely on managers who have very busy day jobs to support that largely. So we could see that was a gap for us that we needed to try and replicate how that system works. So we've gone for a 2-year secondment for somebody to come in and work with us, continue those links with Cardiff to make sure that we are meeting what's heralded by Welsh Government as best practice. That gives us the opportunity to say, yeah, you advised us to go, we've been there, we're trying to replicate what is evident that works, and it gives the opportunity to bolster our system. But I totally take your point on board.
I've got Larissa, and then I'll put down.
So just your question on the annual plan. So what we've put into the annual plan, we've prioritised all of the capital. A&E is obviously at the top of that, because you're right, there's significant issues in terms of the configuration of the unit. So as part of our submission to Welsh Government, we've put that as top priority for governance, for the capital. What we've also done is then looked at the GMOs with the criteria that we use that I described in the annual plan, and targeted intervention is obviously at the top of that. So and the frailty model and the investment sits as a green GMO, a red GMO that's been included in the plan. So that submission went forward to Welsh Government and is included in the MDS submission. So that area is covered off at the moment in our financial assessments on the 51 million.
Thank you very much. That's clear. Richard, you want to?
As a quick question and comment on the GIs. So I think the distinction between in the area of TI, hospital acquired versus the broad issue of healthcare acquired is helpful in that, so we don't underestimate the challenge overall of healthcare associated with antibiotic use, including community prescribing, etc., and separating that out from hospital acquired, where we obviously have patients who are in hospital are more vulnerable, and what we want to do is to be really clear that we have governance processes in place to prevent the spread of things like respiratory deficit, particularly in hospital. So I think that's good. And from a TI perspective, I think in terms of the level of concern reflected in TI, it's helpful to say, make that distinction in the sense that, well, we really need to make sure that we have the right governance processes and controls in place and adherence to standards of practice in the place where the consequences are gravest, if you like. I was just wondering, it's a technical question, in terms of how we measure hospital acquired, is that based on where the test is done, or is that after analysis? Is that after individual cases have been reviewed? because clearly you could have a community acquired CDIP, but if your test is done at the point you arrive in hospital, I'm just wondering the technicality of how we're attributing a label of hospital acquired, so we can really be clear that these are the patients where we can have most impact in reducing incidents, you know.
It's a time frame normally, so if it's within 14 hours, it's not so much the testing that's onset of symptoms. And then you would have similar, if people are discharged, if the infection occurs within 48 hours, it's likely being required in hospital.
So it's after the analysis, basically, anyway. Yeah.
Thank you. Any other questions for Deb? No, so I concur with the views. It's a really helpful report. It's very clear, it's very focused, which is exactly what we need. And it's good to see that we are making some tangible progress. And that is, you can see that in the report, and that is being reflected in wider conversations. So this will come to board every public board. Excellent. Good. Thank you very much. Thanks a lot there. Okay. So the next item then is key issues report. So we've got first of all key issues report for health and safety.
Yeah, okay, so this relates to our meeting back in March. We did not have a meeting in April, so it's a little bit out of date. The key matters are in the report there. We received a deep dive into one of the policy priorities, which is end of life, and we noted that good progress had been made in that quality priority. We also received a report on progress against the it was the PMAT review action plan into the Wells Fertility Institute. Good progress had been made back then in March, but Christine may want to give us an update on progress right up to date. We also received a report on clinically optimized patients, and members raised concern that although huge amounts of work are going into this, into efforts to reduce the number of clinically optimized patients, the number stays stubbornly fixed at around 250 on average, which is expensive and is blocking our yield, so efforts must continue. And we had a service group highlight report from mental health and learning disabilities, and one of the issues that came out was that group is experiencing high vacancies, staff vacancies, which has an effect on quality, obviously, but it also has an effect on finance, because that is a service group which is overspending, as we heard earlier, overspending in terms of agency usage. So that's all I would say, and I'm happy to take questions. Let Christine come in and WFI.
Yeah, thank you.
Yes, I say we have made positive progress. We've appointed a new service manager who started last week, who comes with a lot of experience. The HCFA visited us last week, and verbally we have a small number of recommendations they raised. We haven't yet had a written report, but it was a much more positive visit in their verbal feedback. We have that report, and we are put out for expressions of interest for new persons responsible to manage the licence, and we'll be interviewing from our staff. We've had 5 people who've sat the exam, so we are confident we will fill those positions. So it is in a much more stable position, and we are working with WISC on this, and we'll discuss at what point we discuss de-escalation, because we are level 4 with WISC, and we have, I think the agreement between ourselves and WISC was after the inspection, after we get the report, and we are in a better position to discuss.
Thank you, Katharina.
And we've got 2 reports here, one from the March committee, which is, as Steve says, slightly out of date now, because obviously we are looking at the financial positions at month 11. So I won't go into that, because in a way we've moved on. In terms of performance, I suppose it could be reassuring to members that we are looking in detail at all of the areas that are within the targeted intervention prevention and enhanced monitoring, and you can see that from the report. In terms of the other areas that we looked at during the March committee, particularly speech and language therapy, we had a deep dive into that, and it was good to note that progress is being made, although obviously there's still a large number of people waiting for follow-up appointments. But I think they have made a lot more progress than they have in the previous iteration of this. The concern, I suppose, that still remains is in terms of neurodevelopment performance, and that appears to be the case across Wales. What we have asked is for a further report on that in the next couple of months, because clearly there's a very long waiting list, and this is not almost really we would want as a health board. And these are people and children who are quite vulnerable, and often the parents are struggling really to cope. So in the sense, if we can do something to move that on, there does appear to be a problem with qualified staff across Wales in this area. And maybe there is a need to think, in terms of the country as to what we can do in terms of training resource. And the last thing we looked at during that committee was the State's quarterly report, and particularly staffing in relation to some of the areas like the trades, which are, they're struggling to recruit, and how we can amend working hours and working conditions to attract more people into that area, because we can't manage without. The second report on April's committee, it was notable, and I would say this, congratulations to those people involved in terms of bringing us in on our control total, which was very commendable. Again, we were looking at the plans looking ahead, and that particularly was in more detail in this week's performance of finance in terms of looking at our financial plan for this year. The only other thing I would mention is the theatre efficiency. We noted that a lot of progress has been made, but clearly with the new theatres that have come on in Neathcote Talbot, they are looking at how we can ensure that the utilisation and productivity is the best we can offer. Necrophema, there was some good progress noted there, and I think endoscopy has already been referred to, but obviously that is an area that we are focusing on going forward, because again it comes into the figures related to targeted dementia. I think that would be it.
Thank you. This performance and finance committee is a heavy committee at the moment, but it's playing a really important role, and I thank you for your chairmanship of it, Rena, but it does provide a significant degree of assurance to the board. Any questions for Rena? No? Okay. Yeah, sorry, Darren.
It's not a question, it's just a comment rather on the long-term agreements.
Yes.
There's very good discussion on between us and the health bodies, and the income tax where we've got service level agreements with clinical visitors. Just important to note that that process is due to conclude at the end of June, and we're actively engaged with health boards and trusts to agree with LPAs, and that's a sort of formal part of the business.
And that will be different to previous, because there's been an element of block around it, hasn't there? So that does bring a degree of risk into the financial, the link between performance and finance, doesn't it?
Last year, the board will recall the provider condition also delivered, which is related to the activity that we've been on it for, we could benefit into that. But also where our patients received services from other health boards, they under-delivered. Whilst there was a financial benefit to that, the amount of patients didn't have the treatment to the bottom of the contract. So that dynamic will become fully live this year, part of the negotiation at the moment about the financial uplift. And then the various, across the course of this year and probably future years, we'll start to look at the rates, the high cost procedures given the nature of our traditional process.
Yeah, that's important.
Jane, just to point out, I think there's a typo on page 132. There's this 3-page report, or 113 of 366. I think it should read members were informed that in the development of the plan, some basic assumptions had been made on years 2 and 2. I think maybe 2 and 3.
Yeah. And yes, good to see people are reading. Yeah. Good. Excellent. Any other questions for Rena? No. So we'll move then to the Nurse Staffing Act. Gareth.
Thank you, Chair. And as we know, the Nurse Staffing Act Wales became law in 2016 with the extension to paediatric areas in 2021. And this report covers a reporting period of April 21 to April 24 and forms part of the reporting and assurance process. That's a requirement of the Act set down by Welsh Government. So please reference the key points are the Health Board remains compliant with all legal requirements of the Act. All agreed nursing establishments are fully funded in line with the Act, and the Board has significantly decreased nursing vacancies through student streamlining, international recruitment, and the excellent work of our central recruiting team. The Health Board risk has also reduced from 20 to 12 with a target of 9 being worked towards. So Board has to receive the report as assurance the statutory requirement relating the reportable section of 25B awards and has been completed. That we've taken ongoing reasonable steps to monitor and as far as possible maintain our staffing levels, take all reasonable steps to do that. That the most recent biannual calculation of 25B awards has been undertaken to note the quality indicators relating to falls, pressure ulcers, medication, never-ending complaints, wholly or partly related to nursing care, and note the recruitment work which enables a decrease in spending agency in core areas of the nursing workforce.
Thank you very much. Questions for Gareth? This report has evolved over the years, hasn't it? From something almost entirely comprehensive, something that is actually quite useful and insightful. Anne-Louise.
Thanks. I've got 2 questions. I only just been able to be able to get my papers back up again. So 2 things. One is in relation to paediatrics and band 5 posts generally. Are some of the overseas nurses, who I know some of them are only just starting off and they haven't necessarily passed all their exams, but are we targeting some of them into the band 5 vacancies? And the other one question I had was in respect of retention, there's a line that says that there are only, I've written it down, which I know it's there, having not found it on the report, only 20 of the overseas nurses have left. 20 out of the numbers we've got seems quite high, and I wondered what the retention process is. What kind of future are we offering them that will make them want to stay?
So if I heard you, I'm a bit fair in terms of the question. The first question, are we targeting our all international nurses to work in PEDS?
Yeah.
Yeah, without a doubt. And we've got to a point whereby we've had a major focus on generalist nurses. So your routine band 5, where we recruited probably about over 500 now. So the next point in terms of this year is looking at those areas that have been outside that. So areas like PEDS, areas like NICU, areas like mental health and so on, where we really focus and try to get those vacancies filled there. So that'll be part of our plan for this year, 24-25. We tend to be in a bit of a cycle with paediatric vacancies. Invariably, we tend to get fully established, then staff move on and we need to get there again. And we have one cohort of staff coming out a year, which again, it impacts on our ability to continually recruit there. But yeah, there's a major focus on those sort of non-routine areas in this year.
Where do they go? Why don't they stay to aim for band 6?
Yeah, if you look 20 up to 500 is enough, but it isn't a major sort of walk on there. The real challenge I think in terms of the staff we do move on is that some staff use this as a launch pad to move into other parts of the UK. Those staff that have moved on from us haven't gone home. They've either gone to London or they've gone to Birmingham or they've gone somewhere where we give a really good and robust process through their OSCE. They're ready, they stay with us, and then they move on. And it's really difficult to sort of hold them to account to stay if that's their intention there. That said, we've got to keep a constant eye on that, not just with our international nurses. I think retention generally, you know, recruitment costs us an awful lot of money. Keeping our staff, you know, is something that could really benefit that, I think.
I can see Sarah looking to come in on this.
Overseas nurses in particular, we've undertaken cultural conversations to understand that sense of belonging and what that means, and we've got some thread and we act on the information that gets provided through that. Equally, we've got our new retention lead starting, which has been funded through HAW. That individual has just started, and we really look to bring to life our nurse staffing retention plan along with our wider staffing retention plan. For me, some turnover is good. It's about making sure that that turnover is not out of kilter nationally. And in that respect, I agree, if we could never lose an overseas nurse in Swansea Bay, isn't that what we should be seeking to achieve? Agree with that. So equally, some of the RES information that we are at infancy in terms of understanding indicates that there's some work for us to do in terms of that progression opportunity within Swansea, in particular for our overseas nursing. So all of this will form part of a very focused plan that we bring this information in, which we'll bring to board at the point in time where we're in a position to be able to do so. But you're right to raise it.
And do each of those, or did each of those 20 who have moved on, because it's relatively quickly, were there exit interviews so that we understood where they were going?
Yeah, so exit interviews are offered to all. It's up to the individual if they choose to take it. We can't force people to do it, and that's a really important point in terms of people feeling to speak up safely. But we've also introduced a Thinking of Leaving initiative, which is currently being piloted, and again due to close shortly, which will give us that gives us the opportunity to have those conversations with people before they choose to go. So it helps us almost to avoid. One of the other things the team are looking at in the retention group is looking at how we create a SWAT team so we never lose a nurse within Swansea Bay, how we might be able to nip something in the bud or look at what is it about. Is this about flexibility? Is it about your ability to be able to get to work? How do we support you? Lots of different reasons for different individuals. So these are all initiatives that allow us to truly understand and do the right action as opposed to genericity.
And how long will the initiative run before we can see how effective it is?
So the Thinking of Leaving pilot is due to end next month. And then we'll be taking it through the management board system and through to ward committee in terms of the outcome and whether or not that's something we roll out.
Thanks very much.
Thank you. Richard?
Yeah, I mean, Sarah's outlined a huge amount of work there that's going in terms of retention, and obviously it's really important in terms of international recruitment. I think the reality is turnover is just something that happens, and it will happen with international recruits, it will happen elsewhere as well. And I think from my perspective, if we were offered a figure in advance of how many would actually be leaving, what that turnover rate was, I think we'd actually really grab hold of the rate that we've got, because it's actually really low. And in that respect, I think it's been a big success and has added the full amount of value then to what we do as an organisation. So international recruitment has been a real plus for us.
Thanks very much.
Yeah, thank you. Just one final point on that, the RES data. I do think it's important that as soon as possible that starts to look at progression through the bands by ethnicity, so that we make sure that they are not at disadvantage in any way.
We're awaiting the data has been submitted. We're awaiting the All Wales response from HAW. That'll give us an opportunity.
That's imminent. Okay, and that will go to board. Great, excellent. Thank you. Good conversation. Thank you. Yeah.
I'm just looking at the board responsibilities under the Act here.
Yes.
So we identify a designated person as the nurse director. The last thing on that is specify the arrangements for informing patients of the nurse staff. So what do we do about that?
You know what, if I look at one area where we need to focus there, before COVID, we were in a position whereby we put in shift numbers of nurses on per shift outside every ward. It's a bit hit and miss now, so I think it's some work for us to do, just to be clear that when a patient or their relative walks into the ward, they know that this morning there's 9 staff on, there should be 9 staff, and all is okay there. So not many health boards undertake that part of the Act thus far, but I think it's something for us that we need to get on top of. So we'll be doing some work generally around what our entrance areas look like there, and this will be a really important piece of information there.
And that's something that we need to pick up at the next report, isn't it? Yeah.
Sorry, just slightly out of scope. This act covers these 25B wards. That's not by any means all of our wards. What informs our staffing levels in the other wards?
Yeah, do you know, that's a really good point, and other specialities as well. So if we look at those generalist areas that don't come under the Act, they tend to be our wards where we have longer term care, like some of our wards in Talbot and the like there. Within that, there's a framework of assessment that's very similar to the 25B wards. So while it's not part of the Act, when we discuss staffing levels across those, we bring those into the discussion to see if there's anything that needs to be supported there in terms of the quality, the safety outcomes and all that goes with it there. The real challenge comes when you get into areas like our mental health wards and our LD units and even maternity to a degree there, where you have a different approach to routinely monitoring care and outcomes. So look, birth rate plus for maternity. If you look at the national mental health standards from Welsh Government for our mental health wards, there are other parameters that we work within that are set when we look at those clinical areas. The real challenge in those other areas, I think, is that they haven't had the focus on recruitment that our generalist areas have, which is why this year we'll be looking at mental health in particular. We've actually got 40 mental health international nurses in the pipeline who will be landing with us in the next sort of 6 weeks or so now. So again, there's some real positives there that we just keep focus on the system that we know is trying to invest in.
Thank you, Steve. Thank you. Jean?
One last point. I find the report very useful. Thank you, Gareth. It helps educate. So well done on that one. In terms of the information technology, it mentions the, I say the this to Matt as well. It mentions the challenges in terms of the platform change to Safe Care. Have those been resolved now, or are they still ongoing? And if they are ongoing, in terms of holding our staff to account by the metrics that we're providing, who is validating the information that we're getting from this?
Who wants to go first? Do you want?
Just
Yeah, you start, Gareth, and then I'll bring that in.
Safe Care is our rostering system, and Safe Care is being rolled out across Singleton, Neath, Talbot, Morris and the like there. Not without its challenges. So the information is put in by the wards, it's validated by the matrons, that then is signed off by the group nurse director, and I get a view on it once a week as well in terms of usage and the like there. Now within the rostering sort of principles, there's some really key things that the wards have to do that again is fed back to those local managers there and gives them the assurance as to whether or not the principles are being held to. So if somebody is using an excessive amount of bank, or if their leave is up to 30 or 40% of their establishment, and that is picked up really early and is dealt with really early then. And if you look at some of the information, it's fascinating. I'll send some through to you. It really gives us a view of the actuality of managing our wards across the patch there. There's still some work to do in it, and there's a self-rostering module in that we could look at there. A consistency model, as it's called, whereby we just continue to rejig the off-duty month after month after month. That gives people sort of consistency in what they're working and the like there. But I think it's working relatively well, notwithstanding the fact we still got to embed it properly.
Thank you. Thanks, Gareth. Is there anything you want to add, Matt?
Well, regarding the recruitment issue, it's not an area that I'm aware of, particularly Sarah. I don't know if you want to take that away, Jean.
Okay, thank you very much. So, so for the record then, I think we do have assurance that the statutory requirements related to the reportable 25B wards have been completed. We've noted the ongoing reasonable steps taken to monitor and, as far as possible, maintain their staffing levels. We've noted the most recent biannual calculation, and that will come in the November annual report. Quality indicators regarding falls linked to nurse staffing have been noted, and the recruitment work that has enabled a decrease in spend on agency nurse workforce, which is good. Okay, thank you very much indeed. Okay, so we now come to item 2.6, which is the finance report. And just for the, I think we could take a break at the end of section 2. So we'll finish this and then we'll take a break before strategic items. So over to you, Darren.
Thank you, Chair. The report before us is the monitoring financial position for the Health Board. And this report has been through the Performance Finance Committee this week and received scrutiny there as well, just to ensure the board with the discussions. The Health Board's £9.5 million overspent in the first months of the year, which is clearly a very challenging position for us and concerning given the variation from plan. Our current plan would result in the Health Board being £4.2 million overspent every month of the year. And we are some 5 million off that. There's an illustration on page 4 of the report, which breaks down the planned deficit, the impact of the operational run rate of the organisation, and the savings shortfall in months, which are the 3 key drivers of the financial position, 9.5 million. But beneath that, in table 3, there's a little bit more detail around the composition of those pressures, commencing with the 4.2 billion deficit plan at the top. The £2 million worth of savings non-delivery. You'll note there that mental health and disability already identified their fully targeted savings and are delivering that. And other group plans are expected at the end of next week, and I'm expecting a substantial shift in savings delivery funds. The real challenge comes then in terms of the operational pressures the organisation is facing, which is driving spend above plan. I've got a few key areas, so there's specific challenges around pay, and in particular variable pay. We've seen through discussions so far in board some really good progress in terms of pay and recruitment and retention. And what we're seeing is a slight reduction in variable pay, but the actual pay bill remains high. So there's a bit of work we need to do there across substantive staff and variable staff. We have additional capacity open at the moment as part of the challenges we're facing in urgent and emergency care. So that's the surge bed section at 400,000 a month. And we are still seeing the impact of inflation on non-pay in particular in the organisation, although we have allocated funding for non-pay out to service groups. And on the news yesterday, inflation is dropping. We're going to take a review of the projections on that for the year as well, just to see if there's something we can do. And that was offset in month then by 2 key elements. One was corporate directors who are holding spend at the moment and spent their £1 million in months. And there was 900,000 worth of balance sheet data that we've released position, of which there was very little of that to deploy. So a concerning position in month 1, we need to act. The Chief Executive has written out to the organisation to put some clear instruction in place on the day the position came out. So we acted, there's clearly more that we need to do across now from now of the year. In terms of sustainable financing, but also in terms of arresting this position and getting it done. There are many positive things to go at is where I approach this. Whilst the situation is concerned and serious, continuing to focus on quality, on improvements in urgent and emergency care, we reduce variable pay and take surge beds out. So we know where to go, and this is about the pace and the impact. Given the scale of the variance in month, and the illustration on page 3 just shows what we may need to do in other months to get down to the current plan. And advocating changing the risk rating on financial revenue delivery to 25, which Performance Finance Committee supported. I'd like to get plans in place to be able to reduce that over time. And then what we'll do is we'll look at the actions we need to A, address the run rate problem, and B, to continue the efforts we are undertaking to try to reduce the deficit plan as well, in concurrency rather than delivering those things out. The papers to note, but clearly there's discussion around where we find ourselves and how we go to
Thank you very much, Dan. I know that this is debated at some length in Performance and Finance Committee. Are there any questions for Darren? No. Nuria.
Just a really practical one. In terms of on agency, are there any implications that we need to be aware of in terms of requiring decisions to go through the Director of Nursing? I'm wondering how much time, weigh time, there's always that productivity opportunity cost, but actually, what does it mean in terms of balancing workloads, etc.?
I didn't catch the first bit of your question, sorry.
It's that having that agency, so all requests are going through the Director of Nursing, that's the suggestion on the.
That's the service group director of nursing.
Right.
That's all I do.
You do, that's what I do every week.
But as part of the plan, again, it's reaffirming what we do. So I've had sort of confirmation from services groups of the escalation process and how they manage this. I sign off on non-framework. So anything that's over and above that comes to me and we have a discussion around that. As mentioned earlier, we have some challenging areas where we use more agency than others, but all of that would be signed off with the group nurse director rather than my good self.
Richard?
Yeah, that's a good question. The other thing is, so in terms of the approach, there's an element of trust but check. So the initial period of this, given our concern around that month-one position, is just to reaffirm that the checks and balances are there to the extent that we want them. So that would be the first thing. I think beyond that, there's some questions that we need to ask ourselves. Where we're using agency, could we use bank? And are we not using bank because we don't yet have enough people on the bank? I mentioned in my report was sort of a response from people to the midweek message. One of the comments that I had was, we've got part-time staff who would like to work for the bank, I think, but not sure that everybody knows how to join the bank if they want to. So there's a bit of communication that we need to do to increase the numbers on the bank. We recognise that there's always been a need for variable pay. It's just making sure that A, we're doing it within our resource where we possibly can, and B, well, we do need the extra that we're doing at the lowest possible cost. And we talked a bit about how we need to, the concern around the financial position, particularly the outturn at month one, means that we need to take a different approach, look to people to challenge themselves, challenge their behaviours. How do we get that through the organisation? And some of this would require maybe a period of self-reflection, and that process of empowerment might mean initially giving authority back after we undertake a period of a level of greater seniority during the reviews, and then once they're assured that the process is there, is to re-empower people when we've got our processes now.
So I think all I would say is that the figure that we had in the annual plan of 50 million was not acceptable to the board or indeed to Welsh Government. It is even less acceptable for us to go out 1 month in, so it is entirely appropriate that we are taking immediate action. And the number one thing we've got to focus on as an organisation is to get back to a run rate that is sustainable and that takes us back to a break-even position. That's not going to happen in a year, but it does need to happen over a period of years. And so that focus on driving down the run rate, which I know we have been doing, I know we've been doing at pace, but the pace, I think it's entirely appropriate that the pace is increased and the grip is increased, because we owe it to our population, we owe it to the taxpayer to make sure that happens. So good, thank you very much. So I think the final item in this section is the performance report, isn't it? Yes, so Darren, bearing in mind that we've had quite a lot of this, do you want to give a whistle stop, or do we just say that actually that is the purpose of the performance report in a sense now is to look at the things that aren't in targeted intervention, to make sure that nothing's pulling out, bouncing out that we don't want to bounce out, as we are focusing very strongly on the targeted intervention areas. Is there anything that you would want to say in that context?
In that context specifically, Deb and I are clearly aligning the reporting.
Yeah.
In terms of formality of the report, the structure of the report has changed this month. It's a bit of a work in progress, but it will align perfectly. And yes, to reassure, we do comment on and look at from a performance management perspective and a quality and safety perspective, the other metrics beneath target intervention.
Yeah.
And have deep dives as appropriate to address those. So taking your lead, I won't comment on any other parts of the report, but that's
Thank you. And it is taken in both performance of finance and quality and safety. So I can see Rena's hand.
I was just going to say, because we didn't discuss this at PNF this week, I just wanted to raise page 63, which is about vaccinations and immunisations, Jennifer. I'm quite concerned to see the drop in number of percentage of children who are up to date in the schedule by age 4, which has gone down from September where it had gone up, and it's gone right back down. And then obviously we're not really up to date on the MMR, and there have been recent issues with measles. So I just wondered whether you had any comments on what we're doing to try and improve the performance in those areas?
Yeah, no, that's fine. I think there's a couple of things that have been going on in there, and obviously we will all be aware of the increasing need for us to be focused on the MMR and the catch-up elements. The targets that we're looking at, and we've agreed with Welsh Government we're looking at, is to focus on those schools that are currently running at just 90% in terms of those that have achieved that sort of level of coverage at 90%, and bringing all of the schools up to the 90%, and then continuing to go further than 90 in as many of the schools as we can. So we're working very closely with the school system. The other thing that I would say is we've taken a lot of time and effort to actually look at the child record. So one of the things that that's previously come up is about how we're able to actually view the holistic child record in terms of vaccination. And that's not unique to us, but actually there's been a lot of work that the team have therefore done to actually go in, and in the absence of there being a national record, which is still in the process of being developed, and to go in to really understand what is the level of risk across our schools. So I think some of the data elements that you're seeing is, having now gone into that, what we feel very much more confident in is that we now understand where we need to be focusing our efforts and activity, because we now have a much clearer understanding of which children and in which schools we need to be bringing it back up to the 90. So I think there's a mix of things. So there is actually a lot of really good work that the immunisation team are doing, very proactive, and there's quite large volumes going through that. But we are now, through the data elements, able to know where we need to be targeting, and we're working to ensuring that all schools come up to the 90%, and then obviously not forgetting about the fact that we want to take it further.
Can I just ask, the vaccinations, do they get done in schools, or is it all expecting people to come to GP surgeries?
There's a mixed approach. So there's a nuanced approach, but the team offer mobile, so they're able to go to schools as well.
The schools sound like a good plan, really. You get lots in one go, don't you? Yeah. Okay, thank you. Thank you very much. I don't, not seeing any other hands on the performance report. No, in that case, I suggest we take a 10-minute break, 25 to, that's okay.
No, it's never
Records sit right now, and then I'm
Can I just check it's on mute?
Yeah, that's my answer. I would have been being very
Welcome back. So we're now on part 3, which is strategic items. The first item is item 3.1, which is the Court of Court Progress Report on the annual plan for 23-24, which is last year's, of course. Nerissa.
So yeah, so just to bring you up to date on the progress against the plan. So we've strengthened the governance this year. I think it's important, and I think that's working a lot better. So Deb chairs the annual plan oversight group, and it's in the report as APOG. So apologies for all the acronyms in it. I will make sure that we take those out and they're explained next time. But it has meant that 167 of the GMOs agreed. So, and I think it's easy just to focus on all the things we haven't done, and we haven't done some things, but the vast majority have been completed, and there are 23 that are amber. So, and 18 that are red. Now, of those 18, we've risk assessed these. And use the annual plan scoring criteria. So we've discounted 4 completely, and some of those have moved into business as usual, and they're all described in the report, so I won't go into them in any more detail. And then 13 have been included in the annual plan GMO criteria, so they already are in there. So I was a bit conscious last year that we'll come to the end of the year and what would be included in the plan and what happens for the following year. So that kind of describes where we are. Overall, I mean, there are some tricky things like the prison service. There's some things like DEXA, where we've now resolved the issues around the service level agreement with Hywel Dda. So we are in a position now to start to move forward more proactively next year. So overall, it's been a relatively successful year with those exceptions around those 18.
Thank you, Nerissa. Before I open up for any questions, I've just got a question based going back to the previous section around the frailty hub. That is in the annual plan for this year, so that is part of the thing we've already signed off. So we're not looking.
Sorry,
that is part of the annual plan that we've signed.
It is for next year.
For next year, yeah.
So we didn't have that in this year.
No.
So what we did when we did the GMOs for the annual plan, we did a bottom-up exercise, and she started in September. And so all the service groups kind of were involved in that, and we went through the strategic objectives with you and with them, and they tied back to the vision. So the whole engagement events that we did for the vision document drive everything we're doing. They drive into the strategic objectives, and then the GMOs come out of that. So. And so all of that has been extensively consulted on, and then we did a big exercise sort of from Christmas onwards when the service groups submitted all of the GMOs, and then went through a clear prioritised exercise with a strict criteria that's described in the annual plan. And so the ones that came to the top of that, frailty being one of those, goes into the annual plan for this year. This is the ones that were in last year's annual plan that weren't delivered. So we've risk assessed those that weren't delivered. 13 of them we've rolled over into the criteria for this year, so they form part of this year's plan, the annual plan. 4 we considered as business as usual, and those have gone back into the divisions or into sort of normal business. So, but they've all been through a clear process with clear governance.
Clear line of sight between last year's plan and this year's plan, which have been formed by the work.
Overseen by a new governance process, which Jeb has very kindly chaired and really done well for us in terms of making sure that the service groups are fully engaged, so that we've got a clear process, and there's been executive oversight for all of the processes around the GMOs. So a number of 2 or 3 hour exercises where we've gone through the GMOs, questioned them, challenged them. So by the time it's got into the annual plan, there's been extensive consultation on the man challenge. So I'm confident that what's in there for next year meets all of the criteria that we talked through. But there's a line of sight from this year into next. The year I'm talking about here
into this year. No, thank you very much. That's really clear. Thank you. Any questions for
Just an observation, really. On page 14 of the report, I thought the delivery of the wellbeing objectives by goal in Q4 made quite a stark reading.
Sorry, I missed that, so.
Page 14 and 16. The delivery of the wellbeing objectives.
Yeah, so what we do is we map the annual plan objectives against the wellbeing plan objectives. So that's, so we measure off our own criteria with it, and then what we do is take the wellbeing objectives separately, so we apply all of those GMOs attached to that, and so most of them are kind of off track. So that's the areas that we really need to have a think about. And when we looked at the strategic objectives for this year, we did take into account the sort of wellbeing objectives as well within that. So we do need to be really measuring these. I don't think we're as tight on these wellbeing objectives as we can be, and we have rolled them into the strategic objectives for this year. So we need to put that into the lens for this year's governance really, Jean, to make sure that we're monitoring these as tightly as we are against our own criteria.
Yeah. I can see Jennifer wanted to come in on this.
Yeah, I mean, I think that, just following on from that point, I think we recognised that we had a set of wellbeing objectives that seemed to not sit with everything else that we had. So given that we have now got the population health strategy, which has been approved, so there was a conscious decision to start to use actually those Marmot principles, which we've used as the core framework, because that's where our evidence base is, and brought those in more explicitly, so we've got better alignment. We've also been doing work to actually then think, how do we capture and measure those? So we've been doing some work around strategic indicators that go alongside that. So, and that then will lead to, well, what are the other sort of tactical sort of measures, and therefore what's the operational elements, and all of that then wrapping up into thinking, what are we as an organisation holding ourselves to account in terms of measuring ourselves against success? Because given that well-being objectives by their very nature are not completely within our gift, so we can measure our own, for example, staff well-being, but in terms of staff and recognising that they live in communities and they have families, and we have a duty to all those who live within Swansea Bay, it goes beyond that, and it's recognising that that differential contribution, so that we have regard to what's happening overall strategically through partnerships and through the work of others, and we're also recognising what is our contribution to that. So there's been a lot of work in reflecting on the fact that they weren't quite matching up as we would have wanted, and it made sense with the strategy to bring it together.
Thank you, that's very helpful.
It's strengthened for this coming year on it, because it drives, so the population health strategy drives, so when I describe the plan, it drives the plan. So, and therefore you've got to measure the wellbeing objectives as part of that. And if you look at where we are, we're about half on track, half not on track on a lot of those. So that's the work in progress really for this year, so that we start to get those strategic indicators to underpin what we're putting into the plans for future years. And it ties back to the work that we talked about, the sort of board development around the sort of the development around the social economic development of the agenda, and how we start to move forward with that, so that we're playing a greater part in our role as an anchor institution in the wider economy and population processes and health.
And if I can just quickly come back on that, and I think that's the important piece. So whereas we look at the RNS plan, it is just one very small set of actions, whereas actually the approach that we've taken going into this year's development plan is to actually look at the totality of how we do our business. So in the RNS plan, we've challenged ourselves as an organisation to think how, in delivering those GMOs, how can we do that with a population health lens? So if it is an element around estates, how do we think about that from an anchor piece in terms of who we're contracting with and who we're bringing in to work in those spaces? So it's really changed the nature of the conversation. And whilst we want to embed it as the way that we think about all our business, including our RNS plan, we're also taking it much broader than that, because the contribution needs to come from things that are business as usual and not necessarily articulated in an explicit way in the plan.
And so all the foundational economy work, there's a lot of work to do in this area around making sure that we're playing our part as a major employer and a major provider of services within the broader population and economy. So, and we're not doing that sufficiently well, which is what I described in the board's workshop in April. So, and we'll need to come up with a strategy to be able to support that. We're doing it in a fragmented way, and we need to do it in a more kind of cohesive, engaged way, really, because we respond at the moment rather than actually help drive the agenda. So, I mean, we're beginning to do it with Tata, to be fair. So the work that I'm leading on with Tata now is beginning to have pay dividends in terms of a broader discussion and our role in there as a broader provider and influencer of things within the population. But there's a lot of work to do here.
Thank you, Martha. Nuria.
I agree with you. I think that if we had to pinpoint an area where we really need to put a focus on is around this. I think that there is a mindset that we need to have when it comes to it. And I think it's about changing the way we look at the plan overall and what the implications are in terms of population health, etc. For me, that takes time. So it's about how we can monitor that as a board, which is the next step, and get that assurance that it is actually happening. And that we're facilitating the engagement of partnerships to join us in that journey. That for me is the element that we need clear clarity on.
Thank you. Okay. I think if there are no other questions on that, we are noting this and we are approving the changes to the plan where the delivery is on track and approving the updated minimum data set for the submission for government. Yep, great. So we now got a report on the estates strategy priorities. Dan.
Chair, 14 pages of update, I'm afraid, so I won't go into a page on it.
No,
Just make out the salient points, but hopefully it's informative for colleagues on the board. Page 5 just said that we've finally sold a health centre, local authority.
Right.
As part of the discussions we were having towards the end of the financial year, that we retain tenancy there, and that tenancy will be in place until the alternative model for healthcare provision in that area is agreed, and it's ongoing with slides to do that at the moment. So good piece of work, moved that forward quite substantially, and that will allow local authority to prosecute the changes they want on the road and the infrastructure for what is quite a deprived population in that area. We acquired there's a building called T. Mice Griffiths on Kevin Coy's site. We acquired that at the end of the year with board approval. That allows us to complete the jigsaw of land that we require to prosecute the older people's mental health bill at Kevin Coy's. So we've got now all the ingredients in place for that. Progress on that will be determined by the outcome of the Allward's capital privatisation process, but we're well placed to move when that comes through. And from a Morristown perspective, a couple of things I touched on earlier. So we've secured funding there to complete the reinstating of the front of the hospital. We've liberated a lot of space already. We've developed quite a nice purpose discharge lounge. And what we'll do now is we'll put into place lung function suite, phlebotomy, and a much needed sort of staff only welfare area as well. And we'll return that to its former glory. I think it's a really important symbolic point for Morristown into the We've reallocated resources, I said earlier, to meet some of the infection prevention and control challenges at Morristown in the discretionary plan. That is about making the existing fabric better. We still have an ambition and strategy to move to more people with rooms, but that's not part of the day-to-day. That's something to be more strategic for us, an ambition that we won't lose sight of. We're just trying to make what we've got as we can at the moment. And we've used the EFAB money to start 100% of the roofing. Morristown, there's more to do on that, and still we're grateful to the Morristown team for creating decant space, which has allowed us to move far more quickly than we thought to make some of those areas. On page 9 of page 8 is the All Wales programme. That's the prioritised list that we submitted with the annual plan. That's the reference just to remind you what that is and what the pecking order is, and we'll have an update on hybrid next. On page 9 of the report, then we'll just pick up some of the record storage work that we've been doing with Matt and the team. We've wrestled the business case to the ground on this, and after the implementation of this programme, there's a number of very important things. It's centralised record. It allows for us to liberate some space on key sites which are linked to the city deal. That's really important for us as well. There's a lease requirement here, so the business case works from a revenue perspective, but I will get the board to release the because of the machinery we want to them to get that in place. Over the page then, just to pick up on mental health, I'm working with Janet and the team to look at city centre accommodation for mental health services relating to some of the other aspects of this parade, but also bringing alcohol teams. Lots of the buildings are disparate and not in a great state of repair. We started to prepare a bit of a plan to bring some things to life and improve quite vulnerable members of our society. And from a primary care perspective, we've commenced work on a broad development of children primary care. I'm not going to commission a six-facet survey at this stage. It's a revenue burden. We'll get a lot of intelligence from the DCP work anyway. And the local team has recently done an exercise to prioritise risk within their buildings anyway. So we'll bring all of that together and when that's related, but I'd like to bring that to the board in 3 days in chat. And finally, in terms of the private finance hospital, we're 6 years away from the exit of that. We took some really important advice in the last quarter on that. And that advice suggests that we should start to plan for that exit now. Or do we feel that it just start to describe some of the things we're doing in terms of realigning existing resource to work on that, and also then to undertake some really strong survey work to the contract, make sure that the obligations under the PFI are executed as we would expect them. So in 6 years, we have a hospital in the state condition B for so that's what I wanted to cover. It's not everything in the report, Chair.
No, I think that's very helpful, and it's a useful report. Any questions for Darren? Yes, I've got Nuria and Anne-Louise and Pat.
On the 15-year lease for medical records, is there a break course if technology advances and we can digitalize and destroy these records much more rapidly than we currently are able to? That was one of the questions I had.
The answer to that is no. 15 lease deal is considered what we need. I mean, it works for us financially, but also from how many records we do need to manage. And it's not just health records. So phase 1 will see health records. So that's the 3 libraries that we have across the organisation, Singleton, Eaton, and Morriston. We'll be giving up the space in Morriston and moving all of our active health records into the building. But once we've dealt with that problem, which will take a number of years in itself, we've still got areas like mental health records, community care records, human resource records. They are all over the organisation, and we've quantified that. It's going to take that amount of time to do that. But yeah, there isn't a breakup in the lease, and that's what we've managed to negotiate with the landlord as well. We've been looking for the ideal location for a number of years, come close on a couple of occasions, and it's fallen through. The location of this is ideal for where right in the middle of the area, right off the M4, good place for staff to work as well in Lanshamlet Enterprise Park. So it's a good deal, and we've negotiated to this.
The other point is about the quality impact assessment. It is disappointing that it's not here. So I just want assurances that it will not just be a tick box exercise, that if the equality impact assessment shows any way that it would be a deteriorating position, or that we could have avoided any negative impact as a result of what we're doing, but we will promote things differently.
We have started that with the colleague who's helped us make a reason didn't work. And I discussed it with the private.
Thank you. Next is Anne-Louise.
Yeah, thanks. There's the intention that the backlog of not yet destroyed records will be destroyed before there's a move, because otherwise you're in that position of moving house with stuff you don't want and then have to do that and everyone forgets about it, in which case it uses up space that you could otherwise use for the ongoing record storage.
So we've already got a programme of destruction that's ongoing currently since the embargo was released. We certainly will not catch up. We're hoping to be in the building early next calendar year. And a big benefit of moving to the new location is that we'll have all of our active records in one place. So we'll be far more efficient in how we can manage them and make them available, because we're not ready to switch them all off in terms of making them available to our clinicians. We are still on that journey of digital adoption as well. So the plan in its fullest time will be that we don't need to give the paper records at the point of care, that we'll have everything digitalized, but that will take a number of years yet and will require a different type of business case to get an electronic patient record for the organization, for example. But no, the location itself will allow us to optimize our destruction processes as well. And we've got a lot of catch up to do as a result of the embargo being in place for so many years.
And is there a timescale for that the destruction?
We're
You're then catching
yeah.
up on yourself. aren't you?
We're still working through the detail of that, yeah, so.
Thank you.
Pat? It was just a quick point really. It's very good reading through the report to see how it's already starting to flex and adapt to the priorities of the T1 targeted intervention. It was just good to see as you went through it, albeit within a very challenging context in terms of capital availability, but it was good to see that.
Yeah, change. Yeah, no, I think on a wider basis, every report we get is very focused around those key priorities, which is really good. Steve?
Yeah, and some parts of the health board are concerned about this flexing. So with my mental health responsibility hat, the rebuild at Kefin Coed is sort of 15th on the list and apparently slipping down. So what is the thinking there?
And the thinking was to prioritise business continuity and target intervention, because it was higher up in the target intervention considerations, particularly around the emergency department, the associated scanner and the frailty service. I mean, that was done through a really robust planning process that the nurses team handled actually. So everything was scored, everything was assessed based on the criteria, and then based on that, so that was the other plan process. We remain place of hold with Welsh Government sense that they're still expecting the case to come through, and we're waiting for them to launch that. Clearly, we've had the board of Welsh Government, we did the Welsh web. The West at the end of March, but that was to be strategically ready to do it. It was never that's not off the radar. We'll move further down, but it's caught up in the context of the TIs.
Yeah. Okay. And in the same area, you've touched in the report on Glenreid and Tythnoid and Thurton Bridge. Yes, what is, I understand how it, and why we own it, but what's your thinking about the sort of medium, long term?
So just for board members, Caswell Clinic and Tythnoid are buildings that we provide the clinical care from, one through West, one locally. Those buildings don't belong to us, and neither do the estate services that maintain those buildings. And that's problematic. It falls into priorities in other health boards. We've just submitted a request for an intelligence plan to also improve Caswell through our channels. That won't displace other choices from us to develop. There's an opportunity there to repatriate the residents wherever the area from that. What I want to do with the information is have a discussion of whether we end the conversation with them for taking the building, its responsibilities, we will provide support back to the building. The site lends itself to that. It's not a complicated site. There's lots of access and egress and complicated. There'll always be tricky utilities that we manage. And I think that for me, the longer term strategy would be to bring those buildings back into responsibility.
Were you there before the bridge in Bamford? Yeah, because I remember all the conversations. What was the rationale between for splitting the building and the operations?
Well, my recollection, which is hazy because a while ago, is that it was an all or nothing on the site, so the physical asset, because there are other services there which are quite contract mechanic. The site asset went, we retained service provision, and the lessons of the last 4 years would suggest that that was such a hasty and incorrect decision. I've not tested this, will come to mechanics in the spirit of a public discussion, it's a personal view. But I think the alignment of state capital and services is probably something we should aspire to.
No, thank you, Steve. Any other questions for Darren? No, excellent. So I can see that we've got Sue and we are running slightly late. So can I ask the board's indulgence to make a slight agenda change and take the hybrid theatres business case next, and then come back to you, Christine, with the regional pathology. So welcome, Sue.
Hi there.
You waiting? So are you going to? No, it is. Sorry. Yeah, you are still going to introduce it. Yeah.
Very much supported by Sue. With 30 seconds, the development of hybrid theatre has been something in the annals of health board history for about the last decade. So I'm delighted we've reached this point. It's a key clinical get for us in terms of our regional ambition and all the other things we've discussed previously around interventional radiology and services. The teams worked really well to develop the business case. There is a challenging revenue component to this, which we will discuss. But I'll just turn to Sue, cover that. Oh, just to add, this has been through management board and performance and finance committee. Where it's received approval, so it is a ratification decision.
It is the ratification, it is not a board approval, it's been delegated to performance finance. Okay, fine, thank you.
Okay, thank you. First of all, thank you for allowing me to come across to the board today to present the paper. As Darren said, we've presented the paper through Management Board and Finance and Performance Committee. I'm not going to go through the paper exhaustively, other than maybe to highlight the salient points. As Darren rightly has raised, there is a challenging revenue tail to the case. For the purposes of the conversation today, I would like us to focus on the capital requirements so that we don't have a delay in terms of submission through to Welsh Government, subject to approval, of course. And I do think there is more work to do in terms of the revenue requirements, which are alluded to in the paper, but I think need further granularity and pulling together so that we can be absolutely assured what that ask may be. Just by way of sort of touching on why we need a hybrid theatre. So I think it's been really widely acknowledged that vascular services are what I describe a pillar service. A pillar service in that they underpin many of the other surgical specialties that we have, and I think are fundamental to our delivery of a tertiary services portfolio moving forward. And I think we have had considerable criticism as a result of not having the hybrid theatre, and it's given people maybe a reason and rationale for maybe not embarking in the conversations perhaps as they should have. The service will cover the southwest. We are in the process of establishing a wider vascular network. But just sort of the point of clarity in terms of what a hybrid theatre does. So a hybrid theatre is exactly that. It is a theatre, but it has radiological equipment in so that a patient doesn't have to have a two-step process when it comes to a particular treatment. So at the moment, a patient might have a diagnostic and potentially interventional procedure that may need to go to an open procedure. And if that is the case, the patient has to leave one area to potentially go back to the ward to wait for that procedure to happen. That can cause a considerable impact in their overall outcome, and it is why we discuss the use of the CPOD theatre lists in the business case. So CPOD, again, for clarity, these are the dedicated theatre lists that we have for emergency cases that happen during normal operating hours and are known to, in effect, improve outcome because you potentially reduce pre-operative length of stay. The final thing I'll say is that this paper's been developed with the clinicians, so you will know we've got a very, I think, committed and talented pool of vascular surgeons. It does link across to the conversations we've had previously with regards to interventional radiology, and the two areas will work hand in glove. I think we have potentially less risk associated with interventional radiology. We have a potential of a number of candidates who are applying for the substantive posts that we have out to advert, and that can only consolidate and cement the service moving forward. So the board are asked to approve the submission of the paper through to Welsh Government, and that is for the capital requirement, which is circa £10.1 million. And then there is a revenue requirement that with non-pay costs comes into the region of 2.6 million. I'm not asking for the approval of that today. I'm asking that we bring that back, but not to delay the submission through to government for the capital costs. And I'm happy to take questions.
Thank you very much, Sue. Questions for Sue? Yeah. Can you just clarify the revenue position? Because if we get the capital, we can't address the revenue. How does that leave us? And is this revenue one of the priorities in our sort of growth plans?
So the revenue for this would be in 2025-26.
Got you.
So it's not this year.
Got you, of course.
It would be subject to the prioritisation process.
Yeah.
The conversation Sue and I have is threefold. This needs to be re-stress tested.
Yeah.
In terms of this broad assessment. Then there's the benefits realisation, potential bed reduction. And then there's the potential for the patient population here to extend to the health board and maybe an LTL. I don't think we've closed that off satisfactorily yet, and therefore it would be an extreme position with a view to us reducing that.
Yeah.
And that would form another capability to the board, so if the board is minded to support the case. I wouldn't want to introduce a £2.5 million burden into the organisation for revenue. We would look at that and then consider that.
So there would be an opportunity to stop. Okay, fine. So what we are asking the board to do then is to approve the direction of travel, in particular asking for the capital. There will be a gateway position in terms of next year's revenue, but there is that we think there's some upside in terms of what we might be asking for in any case. And in a sense, this is something that we really need as part of our regional service for emergency and emergency care.
We may, Sue, correct me if I'm wrong, we may well be the only centre that doesn't have.
Yeah, that is correct. It is correct.
No, fine. Okay, so look at the basic questions. Any other questions from board members? Are we happy to? This is
It's to do with question you've asked, which was exactly the question I was going to ask, but it's about a savings plan. So the revenue cost they'll feature as part of our savings plan moving forward in terms of they come close. It looks like the savings come close to the revenue cost, so it's that long term and us being able to keep track of that.
Yeah, and I think that's part of that will be part of the gateway, won't it?
Part of the gateway and weave into the planning process for 25-26, which we're doing as well. There's a couple of checks and balances.
Yeah. So I think that's the line, the sort of the situation is that it's something we really need to do. But we would like to get the revenue down as part of it, so that we don't put ourselves in a difficult position for next year, but it's next year's question in any case.
Yeah.
Great, okay. And this has been approved, so this has been scrutinised significantly in performance of finance, so this is the ratification here. Jean?
Did I read somewhere that this can result in a reduction of 4,000 days?
Yeah. It is a massive, yeah, no, it sounds like a no-brainer. I just wanted to.
Do you want me to respond to that? Sorry, it's quite hard to see in the room, so.
I think we recognised that it probably was the 4,000 days. We saw you nodding.
Yes, yeah, it is. It's the 4,000 days, which will be a combination of perioperative length of stay. It will be a combination of a higher level of intervention for the cohort of patients, which one of the things we have across the area is the highest amputation rate. And so that obviously has a very significant length of stay post-operatively. And it's also the greater level of intervention that may have to happen as a result of us not being able to do the procedure in tandem.
Yeah. Excellent. Okay, so I think there's great support for this. So that's great. Thank you very much. Thank you for coming, Sue.
No worries. Thank you all. Bye-bye.
Thank you. Okay, so we'll now go back to item 3.3, which is to receive the regional pathology memorandum of understanding. Chris.
Yes, so thank you. I'll introduce Neil. Neil Miles is the programme director for this regional pathology programme. Sorry, he was unable to join us today.
Thank you.
In the room.
Oh, sorry, Neil. Yes,
sorry, not screen. Okay, so pathology is a core clinical service that underpins all of our pathways in terms of diagnosis and in terms of managing treatment. Nationally and internationally, we do have quite fragile services in the area in terms of our estates and in terms of our workforce. And for many years, we've been working on developing regional services that across Swansea and Hywel Dda to help address some of those problems and the estate issues around that and the workforce issues as well. So there's two parts to the programme. First is the development of a regional pathology service and via an operational delivery network, and I'll come back to that in a minute, with Swansea Bay as the host organisation, and both Swansea Bay and Hywel Dda commission that service, which is hosted in Swansea Bay, and the development of a hub laboratory of excellence on the Morriston Hospital site, and that's in the capital programme as well, which is a regional service, which provides a single regional service for cellular pathology and a hub and spoke model for blended sciences is the aim for that. And also local refurbishments where there needs to be laboratories on other sites. That also includes microbiology, which is hosted by Public Health Wales. So it's a large programme, and we looked at what the organisational models for that, and the options were a managed network, some sort of collaborative process, or an operational delivery network. The legal advice was that we had an operational delivery network that was hosted in one organisation that employed all of the staff in that, and that's the model we've gone for. So we've taken a lot of legal advice to get to a transitional MOU, which is what we're bringing to you today. I'll let Neil come over to that. I said, and also, this paper is also going to Hywel Dda board next week as well, as they voted in today. So it's going to both boards, the same bit. And there are some slight amendments we'll talk about. And it's over to Neil now. Pass over to Neil to talk about the ODN and where we are and anything else you think you need to pick up.
Okay, thanks, Chris, and apologies I couldn't be with you all today. Can I just check? Can you hear me okay?
Yeah.
Okay, great. Thank you. Thanks, Chris, for the introduction. The paper really sets out the next steps in the ODN and our sort of next step really on regionalisation and transformation of the pathology service. What the Memorandum of Understanding sets out is a transitional arrangement that will take us to the end of the financial year and put some clear governance around those who are charged with forming that network and protection for both organisations in terms of risk and accountability of pathology services for that period. What I'd say in summary is it doesn't necessarily change a huge deal in the short term, but it allows us to work together much more closely to prepare a final MOU to come back to both boards, ideally in March, which sets out the detail of the service specification and commissioning arrangements for the service and the balance of risk and accountability for the service going forward, along with the assurance and governance arrangements, and how both boards will receive assurance of the continued provision of pathology services and any decisions that need to be made over coming months and years. This does bring us in line with where pathology's been across the rest of NHS England over the last sort of 10 years, with clusters of trusts working together as networks to provide services, and Northern Ireland and Scotland are moving to a similar model as well at the same time. So we are a little bit ahead in Wales. Betsy in the north obviously runs one pathology service within its own boundaries. In the southeast, conversations are just starting to develop around cellular pathology only as part of a network. And therefore, the National Pathology Programme is very keen on learning from our progression in Southwest Wales on how we move forward. So I'm happy to take any questions in any detail. I could talk about it for a long time, but I'm very conscious of your busy diary. Thank you.
So can I just pick up, Hywel Dda has for some minor amendments to 12.1, 12.5, which are around clarification around the wording around 2P and something around the organisational management and how we manage it. I think their version, those amendments have been made. We are agreeing those and we will send them around. So there will be some minor amendments to this MOU. What we're asking is in principle. As I say, and also the MOU is to allow us to move on to transition. So we do expect there will be changes through the year anyway. We've had a lot of legal, it's been supported and developed by shared services as well as our own corporate legal and risk departments. So yeah, we've taken into account some of the comments that were brought up in earlier discussions as well.
Yeah, and just flag, we discussed with the managing board in Swansea Bay and the equivalent executive team in Hywel Dda on the development of this paper and the MOU itself.
Okay, so thank you. Rena?
Given we've had difficulty in recruiting staff in this area, Chris, do you feel this will, if you like, give us a momentum to enable us to recruit, because we're going towards this regional approach with better facilities? Because in some ways that's been the problem, hasn't it?
Yeah. So in cellular pathology, there is a difficulty in recruitment. Swansea Bay have been much more successful than Hywel Dda in that area. There's a lot of vacancy in Hywel Dda. I think the reason we've been successful is because of the development of this programme. And so that is, I think the fact that we develop in regional much more digital infrastructure is attracting people. So that's in cell path. In blood sciences, the biomedical science side, I think again, there is opportunity in that. So we do need to think about that's a biomedical science problem. We would deliver still across many sites. How we do that, there's some thought about rationalization. So it would definitely help in both of those areas. And it also, as in Swansea, we've got a very good record of developing advanced practice in biomedical science. I think there's a great opportunity in Howell to bring that team together, and that's what this will start to do. We're also already under an MOU managing the mortuary across Swansea and Howell because of different criticalities in their service. So we're already doing that under an MOU as part of this as well.
Thank you for setting that out so clearly, because it's a very complex project. I have a question about the OBC submission, if I may. I notice it's kind of a bit on hold at the moment. Is that correct? And so the timeline you're still hoping for is OBC 25, is that right?
Yes, but it is held up with the capital prioritisation. This is a big capital project. Neil will tell you the numbers. So I think it was firstly held up because of the increase in cost from the SOC to the OBC. We've done a lot of work to try and bring that back to what Welsh Government think is reasonable, but it's still quite a big cost because of inflation and because of what's required. It is in the capital prioritisation process. I think there's recognition in the Health Board. It's in the capital prioritisation process for Swansea Bay, because we would be the host of that, but it's a regional project. And so I think also through the diagnostic programme, they're also trying to rationalise some of that in terms of regional projects and then only Health Board prioritisation. So it is held up for that. I think the ODN will be much more successful if you have a single building, because the estate for South Bath is very poor and the recruitment is poor. So it does depend on the building.
Thank you.
Do you want to add to that, Neil?
No, it's all correct. Just to put some numbers on it, the OBC estimate of 1 to 200 Reba Stage 2 design was around £188 million capital. The square footage of that building, as the paper says, was 14,000 square metres. That exceeded Welsh Government capital guidance on growth in area and cost between SOC and OBC quite significantly. So we have relocated the building on the Morriston site and revised the schedule down to 9,000 square metres. We're just awaiting the outcome, obviously, of that prioritisation process nationally to confirm the fee availability to re-engage or continue to engage the supply chain partner to finalise that OBC. We anticipate that being a 10-month process. So we're running a risk of not completing that within this financial year. The FBC would be 12 months and it's approximately a 3-year build. So we're about 5 years away from a building at the quickest point. And I think forming the ODN first allows us to sort of optimise some of the workforce models and operational practices to inform the design of the building, but also to ensure we're clear on what efficiencies we're going to be able to deliver if and when we have a new building to operate in.
Thank you. Darren.
I'm just going to comment on this commissioning model for this service rather than for the building. I've met with colleagues on this. At some point, there will be a model where resource is going to start to move around and requirements to commit resource will play. And potentially one body will be asking the other body to do that in the context of financial challenges, et cetera. So I haven't got a solution for this at this stage. We just want to make the board aware that we're very mindful of how resource could shift across the system in partnership. I mean, to be really clear with the governance routes are to make sure that no body corporate is exposed in terms of additional cost because of the actions of another. So that's what commissioning set up through the ODN is something we're going to look to for some of that clarity to make sure that's done in a balanced and proportionate way.
That's really important, because overall we should get greater efficiencies out of this. But between that, you've got shifts depending on people's organisations' current service specifications and everything else. So yes,
variation.
Yeah. Jean?
Darren's just.
Okay, fine, okay. Okay, so we've covered it slightly more widely than purely the ODN, but I think it's useful to get that context because this is a really important development. I know that there is a lot of support for this direction of travel. It's absolutely the right direction of travel. The question for me, given the challenges around pathology capacity now and over the next 5 years, it's only going to get worse. This is not for the ODN, I hasten to add, but are there any interactions, helpful or unhelpful, between this direction of travel and our ability to provide that capacity in the interim?
There's a couple of things that we are doing. So in terms of a digital strategy, we've got a regional digital strategy. We are looking at a single implementation of balloons next year. We are going first in Wales as a region. So that's already worked through, and Matt and his team have been working very hard on the digital piece. There's the digital pathology piece as well. Again, we would want to implement and train and support staff across the network, and that would be part, this will start to allow us to do this, to give us people to work across the network. So there's a lot going on in that capacity. We'll also be looking at the best models of service in terms of consolidation and efficiency. We're looking at joint procurement across this. So I think, I think all of it is aiming us to be able to act much more efficiently and in a much more joined out way, which will bring efficiencies. Sorry, there's also risk because even though both services are called pathology, they don't operate in the same way in some ways. In terms of ability to meet accreditation standards, there's a bit of uplift needed to be done. So I think all of that is going to help us in terms of, looking at more efficient models, looking at flow, looking at lean, looking at transport, using capacity in different ways on different sites than we do now. So it won't solve the problems, but I think technology will help us with quite a bit. Thank you. And very much, remote working, that sort of thing.
Okay, I'm not seeing any other hands. I think we're being asked to support this, which I think we're very, 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 very keen to do. Thank you very much, Neil, for the clear explanation. We look forward to this coming back to the board in due course. Okay, I know it's only an hour since the last break, but I think I'm going to be shocked if I don't give people 10 minutes lunch break. So we'll take a break and then we'll come back to back at 25 to if we can. Thank you. Welcome back. We are now at part 4. Oh, we're actually running slightly ahead of schedule. I was very mean in the lunch break. Part 4. Okay, good. So we start with the key issues report from Workforce OD and Digital Committee, Tom.
Yeah, thank you. As you can see from the report, from a risk perspective, obviously, really the risks are still above appetite, but I think we've addressed a little bit of that. That's had significant committee scrutiny and mitigation in place, and what I think I'll talk about some of the specifics. Workforce metrics, as before, I think we've mentioned PADR compliance and Statin-Man training. Do some positive work on mandatory and statutory training, but there's still some wider work around PAD compliance, but I think that has been addressed in a meaningful way to think about how we supporting staff. That there's not just a compliance piece to say, tick these off and get them signed off. It's actually, these are meaningful conversations and they're about their developmental for staff. So there are work and interventions in that space. We've already covered a bit of recruitment and retention more broadly, but there is more detail there in the paper. We have spoken about nurse staffing levels and specifically around the Act in the previous paper, so I'm happy to take any wider comments if needed. But I guess specifically around neonatal, what that looks like in a staffing levels and provision, particularly to maintain the service and to address specific concerns and challenges with the service. Had a very, very positive deep dive on employee relations and think about kind of best practices. I guess that was acknowledged by one of the awards at the recent HPMA awards. And I guess to note the ongoing work around the digital strategy and how that's developing. So I think really, really positive, mature thinking about where we've come from and where we're going to be going with our wider digital strategy work.
Excellent. Great. Thank you very much. Any questions for Tom? It feels like the committee is really starting to find its feet and have some substantive conversations, which is really good. And at a strategic level. Yeah.
Yeah, there's still ongoing work around, I guess, like agenda planning and prioritisation about what we can squeeze into a committee in general, which I think is a perennial problem. But I think that's that bigger view, the kind of the more strategic view, and make sure we are able to kind of prioritise on the key issues coming to the committee, particularly having that reactive ability, but also much more proactive.
Great, excellent. Thank you very much indeed. Okay, so we now have we're now on part 5, Population Health and Partnerships, starting with the key issues report from the Population Health Committee. So it's in there, isn't it? Is in the paper, I think. Yeah. Again, it was a useful meeting. It feels like this committee again is starting to start to gain a bit of traction, and we had some very interesting papers around behaviours and how we're driving behaviours for population health, about our role as an anchor institution, and indeed a bit about TARTA, which will come into this increasingly. I'm handing the committee chair over to Steve, and I look forward to that going from strength to strength. Actually, for me, it's a really important committee for us over the next few years, because we aren't going to be able to deliver anything unless it's through partnership. And population health, we know that's 90% through partnership, but equally some of the work around integrated care is fundamentally through partnership as well. So that's and I do think that one of the key reasons for that committee is to seek assurance, but also to change the behaviours within this organisation, because I don't think we've necessarily been the best partner over the past years. And if we want to work in partnership, we need to be a better partner. So I think it is starting to do that and flush out some of those issues. Happy to take any questions. No. Great. Okay. So we'll now move on to the NHS Wales partnerships. Nerissa?
Yeah, so two things I just want, and I'll take the paper as read, but there's two things I just want to draw out. So the setup of the NHS Wales Joint Commissioning Committee is now formalised. So and Abby Harris is now leading that. So Sian is retired at the end of March, and Abby is working at bringing together East and Wisk into the new joint committee. So it goes through a bit of the detail of the work and discussions in April. And then the second thing really is the regional specialised partnership, so the RSSP, so it's the Regional and Specialised Services Provider Planning Partnership. So it's basically our regional working around specialist services with Cardiff. And that's been making progress, and we're coming to sort of beginning to get some real traction in terms of operational delivery around HBB, so that we've got a model to move forward, and we've put in there the priorities for the partnership going forward, and those are itemised there, and they're in both organisations, annual plans, IMTP priorities. So they're consistent, and that's the work programme for next year.
Any questions for Larissa? No. In which case, we move the next one, which is local partnerships, external partnerships.
Okay, so and so these link more around the sort of RPB, PSB space, and again, I think we are beginning to make some real progress with RPB. It's quite hard work, but I think there's discussions now around really things like pooled budgets and discussions around how we join up commissioning functions, how we can have discussions that are more cohesive. We haven't done enough right yet. We've done something. So the third sector recommissioning programme, for example, is going into RPB space. So there are a few things we've done, but I do think the next stage is really making sure some of those agreements are translated into reality. So this paper just describes some of the things that have been going on in the RPB PSB space. There's two sort of main strategies running through, or three actually. So the older people strategy board, which Deb chairs, is tying together the frailty work that we're doing. So there's a lot of work going on that you've heard about frailty, but frailty doesn't just exist in a vacuum in a hospital setting. It exists as part of a system, and so the work that Deb is leading is making sure that we integrate that into the system. So any changes we make around things like intermediate care, etc., are reflected in that strategy. And then the other two pieces of two major strategies going through the learning disability strategy, which Amy Hawkins is leading from Swansea Council. That's really coming and really becoming a really good cohesive piece of work. So we went through that as part of the SAB2, and then the emotional well-being strategy. I found that quite hard work to get traction on, i.e. we start to deliver it, but we have done a number of things that are in that strategy, like developing community psychology services, so we have two of those now in there, and there's more work to do, I think, around sort of the third sector recommissioning and all of those things, but I do feel as the discussions are progressive, the action plans just on the 23rd of April does deliver a clear kind of set of things that we will do over the next 5 years. I won't go into too much more. The only other thing is around the Western Bay Drugs Commission. So we are having to do quite a bit of work. Keith chaired that, and obviously now that he's been seconded to NHS Wales, we're going to have to find a new chair for that committee. And there was quite a big discussion at that board about what role the health board will play in that. So just to draw that to your attention, but there wasn't anything else I was going to pull out of it really.
Yeah, thank you. I think this is a really much better report than it ever used to be.
Yeah.
It used to be a sort of almost like a set of bullets of who went where, as opposed to this starting to draw out some of the strategic themes that we are working on. So that's really helpful. Any questions on those? No. Well, thank you. Thank you very much, Larissa. Okay, so I think we're now moving on to governance. So item 6.1, which is the key issues report from the audit committee in your area.
So advise the committee, the board, that he was appointed to see the number of overdue recommendations rising, and I would like to reiterate the need for realistic timescales in the management responses and for our services to prioritise the delivery of those actions they have committed to. In terms of assurance, we discussed the approach to the accrual of medical study leave and annual leave in the accounts, and we got assured that the staff had been made aware of the need to take all of their annual leave by the end of the financial year. That was approved. I would also like to alert the committee to limited assurance reports from internal audit. One covered the challenges around the wellness centre and the other one was around additional learning needs. I want to update the committee that on the minutes in February do not reflect the current position in terms of the ALN, and it was discussed in performance and finance too. And I need to alert you of the fact that we may be unable to meet our legal obligations when it comes to the ALN.
What are the implications of that?
It's around.
Sorry, I missed that.
It's the ALNN. ALN.
Chris, should I come in on that?
Yes, please.
Yes, yeah. I think we did have a project support for that. The timescales were over ambitious. I think we need to recruit to that post, and we're going to adjust the timescales. So we have discussed that. The plan is in place, but we need a support to get it, and that's been allocated in the annual plan for this year. So.
So will we be able to comply with legal obligations?
We are a bit behind on complying, but we are working around putting in a digital system with Powys and Howell are, because it's the DECLO sits across the region. We've already agreed to that. We will be able to comply. We will be a bit behind the timescales we originally put in the audit. So that's
okay. When does it come into force? When does it come into force? Is it or is it?
It came in September 2022, but we've got it's a transition.
It's a transitional. Yes.
Transition.
Yeah. Yes. Yeah. Fine. Okay.
So we are a bit behind, but everyone is a bit behind. We're not out to kill.
So we're not adverts.
I think there are tribunals coming through now, and I think some of the legal things have been challenged around it and discussed as well.
Okay.
So there's ongoing work in this area. Alison Wixby sits on the national group.
Does this go to mental health legislation?
Yes, it will come up.
Yes, fine.
It isn't mental health legislation happening on reporting safety, but last time it did go through mental health legislation.
Yeah, it's also been to performance and finance. So
Yeah.
Muriel's been passing it around all the committees.
It needs to go to an operation. It needs to go to a committee other than audit committee, doesn't it?
Yes.
Yeah.
Yes.
And at our last mental health legislation committee, I think we decided that we should take ownership of it because it complies with legislation, albeit that it's education legislation. So I think if we take it, then we'll.
Yeah, that's good. Yeah.
In the last quarter it went to every committee, I think, for different aspects. I think, but again, we're committed to having the resource to this allocated.
So I think if it all goes to mental health legislation committee, that would be better.
That was the government's advice that we need to sort in terms of cases and rights. That's it. Thank you. Nothing more from the audit committee.
Okay. Any questions from your area?
No. Charitable funds? Yes, please. The charitable accounts, there's two sets of minutes. I'm going to do both at the same time. Charitable accounts were signed off by the trustees, and our investment portfolio has improved returns. The advice to board is that the net position of the charity is better than forecasted. That is mainly down to two things. One is to do with the performance of the portfolio, and the other one is to do with staff vacancy. So we'll have to keep a close eye on the in place to do that. And just due to the fact that we've got the Jiffy Ride and the Cutchon Complaint and the Cancer Centre 20th anniversary, so the support of the board for all of those initiatives will be incredibly welcome. And an invitation for you to visit the hub, which is really having an impact in Singleton Hospital and being used regularly, and it's incredibly exciting.
Great, excellent, thank you. Any questions for Nuria? No, it's good, very good. So we now have Mental Health Legislative Committee.
So I was only actually going to talk about the additional learning needs, which we talked about. Everything else, I think, it's all reported, looks pretty clear. On the additional learning needs, as I said, we are now assured that plans and funding are in place to get us to a situation quite soon where we can be fully compliant. But it's a funny piece of legislation. Nobody understands it, including KCs who have been asked to look into it, because it's a mix between education and health. And and nobody's sure quite where the responsibility lies, but we, as health, we see these children first. If they don't go to school till they're 4 or 5, we see them already when they're younger, so we do have a role to play in this, this story.
No, thank you.
But they'll come back to the next mental health committee, which is in August, so I'll be able to report back to the September board episode.
Great, okay, thank you. Any questions? No, excellent, thank you very much. Report on corporate governance issues, Hazel.
So as part of the routine report provides an update and matters considered in committee, versional circular business license and scale. I think the main focus of this report though is board effectiveness action plan, 31 actions, 11 of which are assigned to the board. The remaining actions are assigned to the board committees to oversee. So the report provides an update in terms of where we are and progress made. And then in the July board, we bring back the full board effectiveness action plan just so they can have oversight to see where we are against the actions. But it's just there for the chair.
Thank you very much. Any questions on that? No, fantastic. And then the summary reports from the health advisory groups.
Yeah, so we have 3 advisory groups. 2 have met since the last board meeting. One was Health Board Professional Forum. At the last meeting, they had an update on maternity and neonatal review, continuous flow models, staff survey results, and also an update on workforce policy. The Health Professionals Forum met on the 11th of April. They focused on an update around targeted interventions and cluster plan. And at their next meeting, they're going to have a presentation on the financial position.
Excellent, great. And did the stakeholder reference group meeting on 16th of May?
So we need to.
Sorry, it did, but it wasn't recorded.
Oh, okay.
Yeah.
That's a progress of sorts, isn't it?
Yeah.
Yeah.
But it needs to be recorded next time.
It does need to be called, yeah. Yeah. No, okay. Any questions on those? No, okay, thank you very much. We are down to any other business. Does anybody have any other business? In which case, if you will indulge me, I'd just like to say a few words on my last board meeting. It's been a long few months, and therefore I thought it was timely to look back over the 7 years that I've been on the health board and the 5 years that I've been chair. And there has been such a change over that period, both within the board and throughout the organisation. We have our vision to be a high quality organisation, and that was a vision that was developed through really fantastic engagement, led by our chief executive and our now chief executive, and involving thousands of our board members over the winter, of our staff over a really challenging winter. So we've got a really clear mandate for that vision to be a high quality organisation. And underpinning that, we have got a clinical strategy, Changing for the Future, that went through engagement and that is being delivered. We've got a people strategy, we've got an estate strategy, we've got a digital strategy, and we've got a population health strategy, which underpins everything. And so we've got a really clear direction of travel that we are progressing, and we are progressing in a measured, controlled and strategic way. The clusters have come on in leaps and bounds. They're Wales leading in some areas, and Wales is certainly leading other parts of the UK. We've got the CAMS repatriation. We've delivered AMSR, and I know there are significant issues still around our emergency flow, but that's a critical step, and we've got the next step in the form of the frailty review. We've delivered virtual wards. We've delivered digital developments, first in Wales in lots of areas. We've got electronic prescribing, Signal, and we've got really ambitious plans around that. And at the same time, we've tackled some really difficult issues, some of them of our some clinical areas, some really difficult issues that we have tackled over this period. And then there's the minor factor of COVID. It was 3 years of those 7 years. If you think about it, how much of a difference has this board made and has this organisation made to itself? We do have a reputation for performance and delivery. I know that we've been de-escalated and then re-escalated, but that's alongside many other people in a very challenging environment. And unlike the last time we were in escalation, we've got very clear plans to get out of escalation, and we are starting to deliver on those plans. We've developed partnerships that came through in your thing, Narissa. I think our partnerships is a long way to go, but we've got some really strong partnerships across the region. Local authorities work so well with us. You know, that was one of the great benefits of COVID, how much those relationships developed, and we need to build on those. In terms of culture, we've brought the values to life. You know, we understand what our values are, and we are starting. There's still a long way to go, particularly if you go back to that high quality organisation that we want to get to. We listen. The Guardian Service, please keep the Guardian Service. I think that independent channel for listening is really important. And it teaches you when you go through the Love Awards and the awards that we have, and I'm so delighted that we're starting Patient Choice Awards as well. You know, we've got such amazing, committed, dedicated staff, 12,500 of them. What we can do so much. We have come so far, but we can go so much further. I know that the next few years are going to be really challenging. They're going, you know, it's challenging across the country. But with the team that you've got here and the teams that we've got throughout the organisation, I know that you'll use One Bay Way to rise to the challenges that are going to come at the next few years. And I wish you all the very best in that endeavour. Thank you.
Emma, we've been collecting views from independent members, words that they would like to share with you that they will describe you. Huge energy, underlying calm, excels the values, especially always improving, leaves the health board in a better place than when she found it, brave, focused, approachable, fair. Emma has been an inspirational leader to me, focused, passionate and fair. I valued all her stamina to manage all the demands the health board endures. Emma, fantastic leadership, very fair. Inspirational, supportive, committed, head girl. Professional, challenging, enthusiastic, supportive, thorough, hard work, competent, friendly and fun. Very friendly and supportive, brave in terms of recruiting colleagues from different professional backgrounds, bringing different expertise and insights. Focused, pragmatic and driven. Clear, confident leadership, coped with being accessible and approachable, robust with challenge when needed, but always a pleasure to work with. I will miss her loads.
Thank you. I will miss you all loads as well. It's been so intense coming up to this period that I haven't quite got my head around it. I said to somebody earlier, it's going to be like jumping off a cliff, actually. Right, okay, so thank you all very much. I think we are finishing early. So everybody's got a bit more time in their diaries. Thank you.